Perfect. And if we share a screen, you will get it here. And we can do this one. Okay. So I will pass that for you.
Hi. Yes, I can see the screen while it's working well.
No, that's okay.
Oh, we can't hear you guys.
Okay, we'll check. Speakers, audio settings, speaker phone, same assistant.
Dr. Perez, can you hear me?
Now we can hear you. Can you hear us?
Yeah. Hi, good morning.
Hi, good morning. Sorry for the glitch.
Thank you so much for being here.
Hi.
Our pleasure.
We usually let until so people will log in the last minutes. So we'll let them until like 8:02 usually.
That's perfect.
I just want to make sure I'm pronouncing your last name right. Janjua?
Yeah, that's perfect.
Okay, perfect.
Okay.
Hey. Oh, wow. You made it. How do you do that?
You go down here and then you press presenter view.
So you don't need this.
No. Is that okay?
You're independent. Okay. Fair enough. I can give you a bit more mouse if I change the.
No, this is perfect.
You good?
Yeah.
Ah. Right.
Hopefully.
So we'll wait about 2 minutes and then we'll get started.
Sounds good. Can we just do a quick test? Do you guys see my slides or are you guys seeing the presenter view?
So right now I'm seeing the presenter view.
You see the presenter view, right? Oh.
Yeah, but earlier when you were earlier was okay. I had the just the slides.
Yeah, that's a problem.
Oh, like that, eh?
Yeah.
Mm,
And
okay. Let me try one more time, and if it doesn't work, we'll just go without.
It's okay. You have a few minutes to try. No worries.
Perfect. All right, let's try again.
yeah, that's the one. Which one?
So,
Well, try both. Try
technically-
one and then the other. Okay.
Yeah, technically this one should work.
Okay.
Are you guys seeing presenter view again?
Presenter you again.
That's okay. I have my notes on my Mac, so I'll use it. I'll use that.
Oh, you're gonna need me finally.
Yeah.
Okay, well, at least that would be this. Let's use this.
Yeah.
There must be a way, but I know which one. Okay, I'll pass for you.
Sounds good.
But you might need to point towards the with the mouse.
Yeah.
So I
Okay.
will pass with this with the arrows. Okay. So it will be easy for you. Click here. Okay, now, do you want to check the videos? They're gonna work now.
Yeah, it's working now. It's all good.
Okay. Yeah. Sounds good.
It's just that I'm
Yeah.
asking if.
Good idea.
But we're gonna play a video because we want to know if the video plays. You know what happens.
Yeah. It's
It does work? Yeah, it does work. Okay. Well, listen, man. That's it. You don't need anything. So what do we want from this?
So I'm still missing a few residents. I will send them a message. 1 extra minute and then we get started. 1:04 is the hard time limit.
no rush from us.
Okay, so there's 20 people in and a bit more people will log in as we go. If you're okay, we can get started. We're really lucky this morning to have 2 specialists of pain treatment, and they're coming from virtually from the McGill Pain Clinic. So we have a staff, Dr. Jordi Perez, who has an anesthesia training and who works at the pain clinic. Is that correct, Dr. Perez? And we also have Dr. Walid Janjua, who has done his training in emergency medicine, and he's now doing an extra training in pain management as well. So we're really eager to hear. The floor is yours.
Perfect. Thanks so much, Anne. Happy to be here, and hopefully this is useful for the Emerge group. So my name is Walid Janjua. I'm here with Dr. Perez, and we'll be presenting to you on just a little primer on nerve blocks in the emergency department. So I've had the unique privilege of doing Emerge for 5 years, gaining that experience, and then now coming to do a chronic pain fellowship. So hopefully I have some pearls that I can pass on to you that you can use in your daily practice. The objectives for our talk are fairly simple. We'll talk briefly about why I think nerve blocks should be adopted in the Emerge. We'll learn about some of the contraindications, some of the precautions that we need to be aware of when performing these blocks. We'll touch briefly upon the management of LAS. We won't delve too far into that because we want to get to the good stuff, which is nerve blocks. So we'll talk about some of the equipment that's needed, what kind of support that you need, and then we'll talk about a few blocks that I think are really practical in the Emerge setting. So this is a position paper from the American College of Emergency Physicians, and they basically state that ultrasound-guided nerve blocks are a core skill which emergency physicians are capable of providing to patients. So nerve blocks and regional anesthesia is no longer a skill solely for anesthetists or solely for post-operative analgesia. It's getting a lot more uses, and especially in the Emerge department, I think using nerve blocks as a non-opioid strategy in multimodal analgesia is on the rise. There's multiple other benefits for using nerve blocks in the Emerge. Some of them include decreased resource utilization. For example, if you do a nerve block for reduction instead of a sedation, you're saving on a nurse, you're saving on a second physician, all the time that's required to monitor the patient after sedation. And in some cases, it leads to a quicker discharge, which is so important in our overcrowded Emerge departments. Thank you. Furthermore, Emerge residents and Emerge staff are uniquely prepared to take on this new training in ultrasound-guided nerve blocks. We have so much comfort with POCUS. We're using ultrasound already to perform multiple other procedures. So using ultrasound to do nerve blocks is not something that's far-fetched. It's very easily implemented for the Emerge group, and hopefully some of you are already doing some of these blocks. This paper is a quick paper that highlights the fact that just with a 1-hour training session, Emerge doctors can be taught how to block the radial median and ulnar nerve and carry out complex laceration repairs, Boxer's fracture reductions, and Bennett fracture reduction. So just goes to show that it's something that Emerge personnel can acquire quite easily. A couple more papers just highlighting the same fact. The first paper is a Danish paper where they taught emergency medicine providers in a single-day course how to do femoral nerve blocks for proximal femoral fractures. And they concluded that it's a safe, effective, and easy to learn in a single day procedure by emergency physicians, and that can be carried out in the Emerge department and does not need anesthesia to carry out these blocks. A second paper highlighting that even more complex blocks, such as the interscalene brachial plexus nerve block, which is considered a more advanced regional technique, can also be taught to emergency medicine providers. So this paper looked at teaching emergency medicine residents how to do a brachial plexus block at the interscalene level in a single workshop. And these residents were able to effectively carry out these blocks in the Emerge, and they checked what the retention of knowledge was 3 months later, and these residents showed excellent retention of knowledge. So this is something that's not outside of our scope. Some of the blocks that I want to discuss are highlighted in red. So the suprascapular nerve block, the erector spinae block, which I think a lot of you are probably already using, and then the PENG block, which is a block that I would recommend over the fascia iliaca block. So we'll talk more about these in detail. There's a million blocks that we could potentially talk about, but in a short time frame, I think we should work on just these three. Well, if we have time, we'll talk about the rest of these blocks, but if not, I'll provide and my slides, and you guys can browse through these. Some of the contraindications for regional anesthesia are listed here. Most of them are fairly straightforward. Allergy to local anesthetic, soft tissue infection at the site of injection are contraindications. Altered level of consciousness is an important one, and mainly for two reasons. The first reason is direct neuronal injury. So if you have an unconscious patient or an altered patient, they won't be able to report paresthesias if you put the needle in the nerve. And then secondly, if you're injecting into the nerve, that is what truly causes long-lasting neuropathy and neuronal damage. And an awake patient usually will not let you do that. So it's a safety mechanism to have a patient awake. The second reason is early symptoms of LAST can be very subjective. So perioral numbness, lightheadedness, dizziness. So if you have an altered patient, you're going to miss these early signs of LAST, and that can lead to worse outcomes. A neurologic deficit in the affected extremity that you want to block is a contraindication. I would say more of a relative contraindication. If you have a mid-shaft femur fracture or a tibial shaft fracture, and the patient can't move their foot, for sure you want to be careful because that patient needs ongoing exams. But if you have a little bit of shoulder numbness after a shoulder dislocation, is that we're not really going to intervene on that. That patient's not going to need serial exams. Is that a true contraindication? I'd say probably not. And the last is the development of compartment syndrome. This is again controversial, but something that we need to keep in the back of our mind. Compartment syndrome is so the evidence is both for and against this recommendation. There's no clear consensus guidelines by the societies, but the important thing to note is if you have a patient with a high-risk injury for developing compartment syndrome, so those are closed forearm fractures, closed tibial shaft fractures, high energy trauma, crush injuries, any of those patients, if you're blocking the extremity, you want to keep compartment syndrome in the back of your mind because it is a possibility. So local anesthetic systemic toxicity is a spectrum. So it's an adverse reaction that results from local anesthetic reaching the systemic circulation in significant enough levels. It usually starts with subjective symptoms, lightheadedness, perioral numbness, auditory disturbances, visual disturbances. It progresses to neurological symptoms such as seizures, altered level of consciousness, and then classically the last thing to present is cardiac toxicity, so hypotension, arrhythmia, and cardiac arrest. But unfortunately, like most of our emerge patients, LAST patients also don't read the textbook when they present. So we have to keep in mind that 50% of LAST presents atypically. And that means that these patients do not necessarily have to have the subjective symptoms. They don't necessarily have to have seizures before they have a cardiac arrest. And these presentations can happen in a more delayed fashion. So if the patient's, septic or there wasn't enough uptake into the vasculature initially, these presentations can happen at a later time. So any patient who's deteriorating that you've performed a large volume nerve block on, LAST has to be on your differential for their deterioration. We won't spend too much time on this slide. This is a checklist from ASRA on the management of LAST, and something good to print out and have in the emerge department if we are going to be performing these blocks routinely. I'll just highlight some of the important differences from management from usual ACLS care. Seizures are managed as we normally manage seizures. If there is cardiac toxicity, so significant hypotension, significant arrhythmia, or cardiac arrest, then we have to start resuscitating. Biggest difference is you don't want to use further local anesthetics, so no lidocaine is out of the algorithm. Epinephrine doses are lower. And the evidence behind this is also not great. LAST is so rare, there's no good studies for this. It's all animal-based studies that report a mortality benefit with lower doses of epinephrine. And then with any of these cardiac toxicity symptoms, you want to consider using 20% lipid emulsion. And they basically narrow it down for you. So over 70 kilograms, under 70 kilograms, it's a bolus and an infusion. If the patient's unstable after 20 minutes, you repeat the bolus, you double the infusion. If the patient's stable, you continue for 15 minutes, and then you can stop the infusion. And the max dose is 12 milliliters per kilogram. Lots more to digest, but I want to talk about nerve blocks, so I'll let you guys peruse through this at another time. The choice of local anesthetic in the emergency department is fairly easy. Either we want short-term analgesia or we want long-term analgesia. Our two options are bupivacaine and lidocaine. Lidocaine, you have to be bupivacaine, you have to be a little bit more careful with. It is more toxic, higher incidence of blast with bupivacaine. And our max dose of lidocaine is 4.5 milligrams per kilogram subcutaneous, and bupivacaine is 2 milligrams per kilogram subcutaneous. So how do we prevent LAST? Because prevention truly is the best medicine in this case. So you want to know your doses, and if you're performing a small volume block, 5-10 mils, this is not a big concern. This is not a big concern, but if you're performing a larger volume block, you need to check your doses. You want to use the lowest dose effective. You want to avoid the use of heavy sedation because an awake patient is a safe patient. You want to aspirate before you inject, and then every 5 milliliters. It's very easy for these needles to move around and cause vascular puncture. And lastly, any high volume block, which we always do, we always want to use ultrasound. Lots of literature suggesting ultrasound guidance reduces the risk of blast. We'll talk briefly about the equipment that's needed. I've listed 17 here, so it seems daunting, but don't let that dissuade you from performing these blocks in the emerge. Once you do a few, you'll know where everything is, and things will become easier. Almost all of these are things are readily available in all emerge departments. So sterile towels, dressing, cover, jelly, gloves, sterile prep, needles, syringes, things that are very easy to get. You always want to inject subcutaneous local if you're using a larger gauge needle for your block. And this 8 and 9, the center of our prep here is the most important, the needle and the extension tubing. And we'll talk about that a little bit more here. So we always recommend the 2 operator technique for any, for almost all nerve blocks and regional anesthesia techniques. And it's just a safer way of performing these nerve blocks. The operator is holding the needle in one hand, the ultrasound probe in the other. We almost always use inline techniques. Some very infrequently we'll use out of plane, only if the ultrasound probe can't fit in that area. And the benefit of this technique is it allows you to visualize the spread of local anesthetic under live ultrasound guidance, and that's the safety mechanism. It provides higher accuracy as well. In pain clinic, we have lots of people around, usually another fellow helps me with these blocks, but in the emerge department, I usually grab one of the RNs for the patients, and they're usually very happy to help. And the IV tubing is just an extension tubing. The nurses usually know where these are stored. And one other thing is these guys are using a normal saline flush. And that is, you can use that, or you can connect your local directly. Sometimes we do give some little squirts just to figure out where our needle is. You can do it either with saline or some local. It's not, really doesn't matter much. In terms of the choice of needles, again, we have two choices, either cutting needles or blunt tip needles. Usually in regional anesthesia, most of our colleagues are using these special blunt tip needles made for peripheral nerve blocks, but these are absolutely not necessary. And if all we have are cutting needles, such as our 22 gauge Quincke spinal needles in the emerge department, those are absolutely fine to use. And that's, to be honest, what we use mostly in the pain clinic as well. They're cheaper, they're easily found. They're usually a smaller gauge than the cutting needles, so they're usually a little bit more comfortable for the patient as well. The blunt tip needle, there are some benefits because it's blunt tipped. It gives you some more tactile feedback as you're going through the fascia. You'll really feel the pop as you traverse a fascial plane. On top of that, less risk of puncturing the nerves, less risk of puncturing the blood vessels. So if these are readily available, I think that would be fine, but definitely not necessary. Furthermore, our echogenic needle is absolutely necessary before we start performing these blocks, and the answer is no. Echogenic needles do help with visualization under ultrasound, but studies show only at angles more than 60 degrees, which is very rare. So don't, if we don't have echogenic needles, if we don't have cutting or blunt tip needles in the emerge, that shouldn't dissuade you from performing these blocks. We'll talk about the suprascapular nerve block specifically. And I picked this one out specifically because it's an easy to perform block. Our pain and anesthesia colleagues have been using this block for decades with good success. It has lots of clinical applications for both acute pain and chronic pain. And it's a safe block to do. We could talk about countless other blocks from the interscalene all the way down to the ulnar nerve. And that would take far too long. So this is a good block to start off with. And I think once you get more comfortable with this, you can move on to other blocks. This is a classic example of a patient that we often see, anterior shoulder reduction, 35-year-old playing basketball, presents with shoulder deformity and shoulder pain. And you want to manage this gentleman. So there's lots of options, of course. You could do no sedation and no regional anesthesia at all. You can just do the Cunningham. Some of my colleagues do that and it works quite well. Most of the time we use procedural sedation, but again, requires a lot of manpower. You could do an interscalene block, which is what most of our regional anesthesia colleagues would tell us. But I think this suprascapular nerve block is a overlooked block that has some great clinical applications, and it can be used for shoulder reductions as well. This is the probe position. You find the scapular spine, you translate a little bit more anteriorly, and you look down almost vertically. The needle comes in from a medial to lateral position. This is the anatomy of the nerve. It comes from the brachial plexus above the scapula and goes through the spinoglenoid notch. And this is where we're going to target that nerve. And the reason this works so well for chronic pain and acute pain for the shoulder is that it innervates 70% of the shoulder joint. And this is based on multiple anatomic studies that have been done in the past. And because it innervates 70% of the shoulder, it can be used for a lot more than just shoulder dislocations. This is one of our most commonly performed blocks in the pain clinic: tendinopathy, frozen shoulder, non-specific shoulder pain. I use it often in the emerge department. The patients come with shoulder pain. I can't find any obvious fractures. They're having a hard time mobilizing. This is something that can provide them with significant analgesia, and they're able to be discharged home. This is a paper that I just wanted to highlight. It's out of Turkey. They randomized 40 patients to a suprascapular nerve block group, and then the second group to a procedural sedation group for, I think, anterior shoulder dislocations. And the outcomes were the same. All patients had a successful reduction. Some patients required a second attempt. The number was the same for both these groups. But what I want to highlight is the time to discharge after beginning the procedure. It was 25 minutes for the suprascapular nerve block group and 125 minutes for the procedural sedation group. And the importance of that can't be overstated. When I work fast track, I have 2 rooms that I can do a sedation in, and if I have a patient after a shoulder dislocation that's taking up that room for another hour, that's going to be a lot of time lost. So the way we do this injection is scapular spine. You tilt downwards. This is the zone anatomy we want to see. This is a spinal glenoid notch. The nerve resides within. This is the ultrasound probe position. Needle comes in from medial to lateral direction. The error that most learners make is the angle is not steep enough. You really are almost looking vertically down into the scapula. Just another picture. So the needle is coming in from medial to lateral direction. This is just a quick video showing the block in action. Perfect. So that's so again, medial to lateral direction, and I would use lidocaine 2% for this because it gives a more potent analgesic effect, and you only want a short-term duration of action. All right, so the second case I want to talk to you about is this gentleman, 75-year-old male, fell off a ladder, sustained left-sided rib fractures. So for this gentleman, erector spinae plane block is something that I think is useful. It's possible some of you guys are already using this block. I remember even a few years ago, there was a talk about the ESP in the emerge, and ever since the use of ESP in the emerge is taking it's flourishing in the emerge department. Some of the uses in the emerge have been reported: acute appendicitis, post-herpetic neuralgia, pancreatitis, extensive burns. What I most commonly use this for is mechanical back pain, usually low back pain and rib fractures. I have used it for non-specific abdominal and thoracic pain as well. So most recent example is I had a 60-year-old male come in with acute on chronic left flank pain, multiple previous workups, all negative. It's somewhat of a visceral pain without any obvious pathology, lots of narcotics at home, probably 5th visit to the emerge that month, and we want to avoid using narcotics. So for that gentleman, instead of just giving him hydromorph, I did a T8 ESP, which provided him significant analgesia, and he was able to be discharged home without any narcotics. So lots of uses for this block in both chronic and acute pain. Just a couple papers highlighting the fact that this block is easy to perform by emerge physicians and has lots of unique applications. This is just a schematic showing where we want this block, where we want to deposit the anesthetic in this block. So this is the erector spinae muscle. This is the transverse process, and this plane in between is a potential space, and that's where we deposit the local anesthetic. And we're not depositing this above the rib. We're not depositing it very close to the spinous process. It's right at the tip of the transverse process, and that is important because we want this local anesthetic to go around the transverse process and go into this paravertebral space where it affects the ventral ramus. And that is what gives us that profound analgesia, and usually analgesia of the visceral organs as well, which we don't get in most other in other blocks. I normally perform this block at the T10, L3, or T5 level. And the reason for this is because this is a potential space. It can go cephalad and cauda. This is a schematic that I got from a really great YouTube channel that I'll link at the end, and you guys can watch the full video. So if you inject 20 to 30 mLs of local anesthetic, studies show that the local anesthetic will usually go 2 to 4 levels cephalad and 2 to 4 levels caudad. So you don't need to do this block in multiple locations. The only caveat to doing the L3 block is that you likely will need a curvilinear probe rather than a linear probe, and it becomes a little bit more challenging. And I would never really attempt this block at the L5 level. There's just too much tissue there that you need to get through. The way to do this block is fairly easy. This is this anatomy is something that we're probably very comfortable with, although more in the anterior. So basically a similar picture to what we do for lung slides. Lung sliding, you find the rib that you want to inject, or the level that you want to inject. And the way I do this is I track down to T12, there's no ribs afterwards, and then I come back up to T10 or T5 or wherever you want to inject, and then I move medially. What you're looking for is a rib which is very pronounced, round. You want to see the pleura and a second rib. And once you have this view, you translate the probe medially. And once the probe is translated medially, you'll notice a change in the morphology of the rib, and it becomes a transverse process. And this is a much more subtle bump. And you also want to make sure that the pleura is no longer in view, just as an extra safety precaution. The needle comes in either through the caudal direction or the cephalad direction. If they're sitting, usually cephalad. If they're prone, usually you'll come in from underneath. And you want to inject basically anywhere underneath this erector spinae muscle. You could even go lateral to the transverse process, but it's much easier going on top of the transverse process. It's just a bony end stop and a safer way to do this technique. So this is so this is just a video showing the block. So they're coming in from a caudal direction. Needle goes underneath the erector spinae muscle. And the most important thing here is you want to see the erector spinae muscle lift off the transverse process. Right there. And that pulsation of the erector spinae muscle up and down with the squirts of local anesthetic, that is what tells you that you've done a good block. And they started again just at the corner of the transverse process. That's the more advanced technique. It's not necessary. You can come right onto the transverse process. It'll give you just as good of a block. Because we want this block to be more longer lasting, bupivacaine is probably the choice of anesthetic here, 0.25%. So definitely something to look into and incorporate into practice. The third block that I want to talk about is for hip fracture. So very common presentation to the emerge. 78-year-old male presents with hip pain after a fall, has a history of COPD, CHF, he's found down, perhaps he's already on a bit of oxygen, perhaps he's already had some narcotics with the ambulance and he's still not comfortable. This patient would be an ideal patient for a block. And the fascia iliaca block is something that a lot of emerge physicians are probably comfortable or not comfortable with or know about. Personally, in Calgary, this is a block that we were taught as part of a randomized controlled trial. And again, it was only a 3-hour talk. But I think there's a better procedure than this. But I do want to highlight the fact that peripheral nerve blocks reduce pain, they reduce opioid consumption, they reduce delirium, and they reduce the time to first mobilization. So lots of reasons to do these blocks, especially in our frail elderly population where we want to avoid narcotics or if their pain is inadequately controlled. So the fascia iliaca block, this is what it normally tries to get. Lots of skin analgesia and the femoral shaft. And the indications are hip fractures, femur fractures, and other procedures involving the anterior thigh. But to be honest, we would almost always perform this block for proximal hip fractures. And I don't think this is a great block to do for that, because oftentimes you only get the femoral nerve. You don't get the obturator nerve or the sacral plexus, and the obturator nerve and the femoral nerve contribute a majority of the sensation to the hip. So the reason for that is the femoral nerve is here underneath the fascia iliaca. The obturator nerve is way far out, and the lateral femoral cutaneous nerve is again quite a bit away. And it's, to be honest, the lateral femoral cutaneous nerve is not something that we really need in the emerge department. It's a purely sensory nerve. It helps with the incision, but it doesn't really help us control pain in the emerge department. And when even if we inject 40 mLs, which is what the fascia iliaca block recommends, it's still very rare that we get the obturator nerve, and we're only getting the femoral nerve. And so we're not really providing adequate analgesia with the fascia iliaca block. So I think the PENG block is something that should be adopted more in the emerge department, and it's being adopted in anesthesia already. And there's multiple reasons for this. One, it's a safer block. There's a bony end stop. You're on the superior ramus. The second thing is it covers a lot more nerves. So you get the articular branches of the femoral nerve, you get the accessory obturator nerve, and you get the obturator nerve in most cases. And this provides really great analgesia for the hip joint. You're using less volume, therefore less risk of blast. Studies have shown that there's better pain control than the fascia iliaca block. And furthermore, it's motor sparing. So not as important in the emerge department, but certainly post-operatively, early mobilization is huge. Again, I would use 0.25% bupivacaine for this block. The top left of this picture is what we're usually comfortable with, the femoral artery nerve and the vein more medially when we're doing art lines or central lines. But if you find that view and you go more laterally and you tilt the probe diagonally, aiming from the pubis to the iliac spine in that direction, we want to get this view. And what we're really interested in is the psoas tendon. And this is between the iliopubic eminence and the anterior inferior iliac spine above the superior pubic ramus. This is just a quick video showing how to find this view. So if you can't find your view, you put the probe on the groin, you find the femoral head. Once you have the femoral head and you have the angulation in the groin, you translate the probe superiorly. And when you do that, you find the psoas tendon. The second way of doing this is if the patient's iliac spine is easily palpable, you palpate that, you start on the iliac spine, and again, you move in the same femoral crease direction, inferior and medially. And as you do that, you'll see that sulcus of the superior ramus, and you'll see the psoas tendon lodged in there. So, okay, and this is just the last video I want to show you, and then we'll end the talk. So again, you're coming in from a lateral to medial direction. You want to go underneath the psoas tendon, and again, you want to see that psoas tendon being lifted off the bone, and that's crucial because if you inject the muscle or the tendon, the block won't be as effective. And again, 0.25% bupivacaine is what I would use for this injection. So We won't have time to go through the rest of these blocks, but I can send Anne these slides and you guys can peruse through them. This next one is super important. I use this one all the time. It's called the TAP block. I use it all the time for acute on chronic abdominal pain in the emerge when I don't want to use narcotics. So just some slides on that. I think the forearm blocks are crucial to learn in the emerge department, and the ankle block as well. So, and this is an example of us performing the block. It's probably a 2-minute video. So these blocks are easily performed. Doesn't take too much of your time. So our take-home message from this presentation is that nerve blocks are taking a bigger and bigger role in the emerge department. I think it's time to adopt them into practice, like we've adopted a lot of other techniques into emerge that other specialties are excel at. I think this is something that we can excel at as well. I would start by performing the simpler blocks and then moving on to the more complex blocks. And I think an elective up here at the pain clinic, or a few afternoons with us, or a regional anesthesia elective would be really helpful for emerge residents. And we're always open to have learners up here if you guys are interested. And these are just some links that I think are really important. And this one mainly, this YouTube channel has all the more detailed information if you want to get more information on these blogs. So thanks so much.
Thank you so much for this very great and very useful talk. I agree with you that for sure there's more place to do nerve blocks in the emergency room. I was wondering if you find it rather easy to do it without impeding your flow too much.
Mm-hmm. Yeah, it's always it is a struggle in the beginning, because when I first started doing these blocks, I had to run to the code room to find the spinal needle, because I didn't want to open up a lumbar puncture kit, and then the extension tubing was elsewhere. So now that I've been doing them for a while, I know exactly where things are. So it takes me 60 seconds to gather my equipment and perform the block. There are some emerge departments, at least in the United States, that have block bags. So they have all these supplies in a baggie, and they place about 20 of them, and you just go grab that bag and do your injection. So yes, there is a bit of a learning curve. Initially, it will impede your flow, but when you can discharge a patient after this block, instead of giving them 5 rounds of narcotics every hour, it does improve departmental flow overall, I think. So, but after that learning curve.
Yeah, we actually had a talk last week, and we have in the Jewish General Hospital, they do have these bags as well. And one of their main key points was exactly that, to have material ready and help the flow. I have a question from Monica. She's asking if you also are willing to have some staff come over and get some training.
Yeah. So what I wanted to say, well, first of all, thank you, Dr. Janjo. That was a great presentation. I want you guys to notice something. An ER doctor giving a talk about regional anesthesia, a very good talk, because I know about this topic, and within halfway through a fellowship. So I hope that you understand that the learning curve is very steep, and it's very easy to achieve a very good level of knowledge. Dr. Janjoa is surrounded by anesthetists. So the other 3 fellows in the clinic, they are anesthetists. So the poor guy is alone here, isolated. We keep teasing him, but he has achieved the same level of accuracy and knowledge about anatomy and blocks than the others. And not just because he's very intelligent, which he is, but also because these blocks, if you have the right mindset, they can be adopted very easily if you just work on something very easy, which is anatomy. You guys, you have the skills in ultrasound. This is something that we didn't need to teach to Walid, because he did already have this knowledge. You know how to catch a probe, how to move it. You just need to know the anatomy. And then needle navigation. So my message to you guys is blocks are extremely, extremely dangerous. Why? Because you do a block it works and something changes in your mind forever. And then you start thinking about blocks all the time. And then you start seeing the indications more and more often. That's why they are so dangerous. They are dangerous for you and for the department, but not for the patient. For the patient, it's the contrary. They are safer, they are more satisfactory. And I hate to say that at the pain clinic, we hate opioids. And why we hate opioids? Because we know that if we can do something better for the patient is to provide opioid sparing techniques. The same is true for you guys. You want the patient as short as possible in your emergency room with a block, except if you cause a complication, of course. With a block, you can achieve that. So the message that I want to send you guys is that if you have the right mindset and the right knowledge to learn this very, very quickly, you have maybe indications that we don't have because yours are acute indications, our are chronic indications, but pain is pain. And you have the tools, you have the machines, you have the knowledge, you just need the learning. We're here to provide that learning, not just for residents, but also for the staffs. This is something that it's very easy to achieve. And Dr. Jandro is the best example. He talks, actually, I was very, very amazed about the quality. I mean, you talk about blocks like you know about it. So you can tell that this is something that it's adopted in your mind. And it shows that you have achieved the right knowledge. And we teach people here to be safe first, and then we teach them to be effective. And for your specialty, we can do that very, very easily.
Yeah, Dr. Sir McNanny, we do these blocks on Friday afternoons. I'm sure you're more than welcome to just walk on up here, and then we usually have 5 or 6 blocks every Friday afternoon. So we're happy to have learners there.
I think a lot of people will take you on that. Honestly, it was a really great talk. I have to echo all the comments. We really appreciate it. It was so great that we might have you come back for the other part of the talk. If you're willing to send me your slides, that would absolutely be great, and I'll be in touch with you by email. Thank you so much, and please be welcome and to stay for the rest of the talk. I understand if you have other commitments for sure, but be welcome and stay.
Okay.
Thank you so much.
Take care.
Bye.
Next up, we are very lucky again to have an internal medicine and ICU staff who will come as a specialist of the hyponatremia and tell us what we do wrong and what we could do better. Dr. Spivak, who also happens to have a certain link with a certain Dr. Davis. Good morning.
Good morning. Hi, everybody. So I'm Rachel Spivak. I happen to be the better half of Seth Davis, one of your R5s. So this talk, I guess, we kind of joke a lot in the Spivak Davis household about how nobody understands hyponatremia except internists. On talking about this at one point, and Sophie thought it might be a good idea for me to come by and give you guys a little bit of a rundown as to how we can improve the management of hyponatremia in the ED. Let me just get my slides up here. Can you see my slides?
We do, but we also see the presenter, the slides on the sides.
Is that better?
Can you, if you make it full screen?
Yep. Is that better?
Perfect.
We're good, yeah. So look, I'm very conscious of the fact that you guys are emergency medicine doctors and not internists. So I really tried to gear this presentation towards you guys. I recognize that this is maybe not the most exciting topic for you, especially after having a really great talk about nerve blocks. But I'll try to make it as interesting and stimulating and clinically useful for you as possible. So we have about a half an hour. By the end of this presentation, I'd like for you guys to understand how to interpret urine lights. That's really the crux in the management of hyponatremia. Specifically, how to differentiate hypovolemic hyponatremia from SIADH, because this is one of the most common mistakes we see on the other side in internal medicine as you guys consult us. How to avoid, especially one common mistake that's made in the management of hyponatremia. And if we have time, when to consult IM. So again, without going into too much detail, I have to at least talk a little bit about some of the physiology here. So just a couple basic principles. You guys were probably hammered in medical school saying that hyponatremia is really a problem of water balance and not of salt. And that's to a certain degree true. It's really an imbalance between sodium and water retention. And specifically, we talk about the holding on of more free water than sodium. And that's really what dilutes down your serum sodium, and that causes hyponatremia. Now, to a certain degree, that's true. Now, obviously, if you don't eat a lot of salt, that impacts the development of hyponatremia. But for the most part, it's a problem of water balance. Now, urine lights are absolutely key in making the diagnosis. And when we talk about urine lights, we talk about urine sodium and urine osmolality. Now, the approach to diagnosing hyponatremia is made using a volume status assessment. This, you know, you've read, you've learned, you've been tested on in medical school. And that's really based on the assessment using your history and your physical exam. Now, I'm an internist. We like talking about volume status. You guys like talking about that a little bit less. If I'm perfectly honest, I think that when I assess a patient for hyponatremia, it's really on history that I want to know if there's any history of a predisposing factor to hypovolemia. And the physical exam for me is really looking to see if I see any signs of hypervolemia. But again, you kind of have to go back to first principles to determine which category your patient falls in. Now, this is from Lancy, which is an internal medicine resource, but you guys have seen this in many different forms. I'm just going to zoom down here. I'm just going to assume that we're talking about hypotonic hyponatremia. And of course, we divide things into hypovolemia, euvolemic, and hypervolemic hyponatremia. Really, I'm going to focus this talk on hypovolemic and euvolemic hyponatremia. In particular, I actually want to spend a little bit of time talking about SIADH. So, a little bit of a rundown on physiology with regards to the hormones that are at play with hyponatremia. So we're dealing mainly with aldosterone and ADH. So aldosterone, the stimulus for aldosterone is hypovolemia. And that of course stimulates the renin-angiotensin aldosterone system. And that causes tubular reabsorption of sodium. So if the body is hypovolemic, the body's going to say, well, I'm going to hold on to all my free water. I'm going to hold on to all my sodium because I want to basically have water follow. And that's going to result in boosting up my intravascular volume. As a result, if I'm holding on to all my sodium, my urine sodium is going to be low. I'm not going to pee out any salt. Now, on the other side of the spectrum, we have ADH. So ADH is antidiuretic hormone. So again, you just kind of have to think about what it does. Antidiuretic hormone means that I'm not going to diurese, I'm not going to pee out water. So the main stimulus for ADH to be turned on is increased serum osmolality. Now, so that basically means that as my serum tonicity increases, I'm going to secrete more ADH. Now, to a lesser extent, hypovolemia is also a stimulus for ADH. So when you're hypovolemic, it's really first aldosterone that becomes a more important hormone at play, and then secondarily ADH gets turned on. Now, what does ADH actually do? So in your distal tubules, it basically forces aquaporin receptors in the collecting tubules, and this is going to cause water reabsorption into the body, which basically means that if I'm reabsorbing all my free water, I'm going to be peeing out concentrated urine. And when we say concentrated urine, we usually mean urine osmolality of greater than 100. You might, if you read, different sources might have different cutoffs for your urine osmolality, but essentially if your urine osmolality is above 100, that's usually an indication that your ADH is turned on. So let's just look at this in another way, because this is very important when you're trying to understand what's happening and the reason why your patient is hyponatremic. So again, aldosterone, the stimulus of secretion, is hypovolemia. The result is a retention of sodium. So my urine sodium then is going to be low, and my urine osmolality is unaffected. So aldosterone does not affect my urine osmolality. Now, when ADH is turned on, the stimulus for the secretion is hypertonicity, so increased serum osmolality, and to a lesser degree, hypovolemia. The result is the retention of free water, so holding on to all my free water, As a result, my urine sodium is unaffected, but my urinosum is affected in the sense that I'm putting out concentrated urine, meaning that my urine osmolality is going to be above 100. So this brings us to our first learning point here, which is that aldosterone affects urine sodium. When it's on, urine sodium is low, so less than 20. Now, ADH affects urine osmolality. When on, urine is concentrated, meaning that my urine osmolality is high. So that goes through some of the hormones that are important. I hope I haven't lost anyone or anyone falling asleep just yet. So if we actually now look at this with regards to our volume status assessment. So in terms of hypovolemia, first actually I want to talk about hypovolemia and hypervolemia together, because essentially it's the same concept and it's the same physiology at play for different reasons. So in hypovolemia, my stimulus for aldosterone is turned on, my urine sodium is low. My stimulus for ADH is turned on, and it's appropriate because I'm hypovolemic, right? So I'm putting out concentrated urine. Now, it's exactly the same urine lights that you're going to see for hypovolemic hyponatremia or hypervolemic hyponatremia. So the reason for this is essentially the great paradox of medicine, which is when you're hypervolemic, when you have hypervolemic hyponatremia, you're cirrhotic, you have nephrotic syndrome, you have heart failure, your intravascular volume is relatively depleted. So what your vessels are seeing is a relatively hypovolemic state, but your volume overloaded. So as a result, you have a stimulus for the holding on of free water and of sodium because you want to boost your intravascular volume. So your urine lights are going to essentially reflect the same as they would if you were hypovolemic. So you're going to have low serum sodium, low urine sodium, and a high urine osmolality. So that's hypervolemia and hypovolemic and hypervolemic hyponatremia. Now, SIADH is a little bit different, and this is sometimes where the confusion occurs, I think, in the understanding of hyponatremia. So in SIADH, it's the syndrome of inappropriate ADH secretion, right? So ADH is obviously on, but it's on inappropriately. So if my stimulus for ADH is on, I'm holding on to my free water, meaning that I'm putting out concentrated urine. So my urine is concentrated because I'm holding on, I'm desperately trying to get all of that free water into my system. Now it's on inappropriately because I'm euvolemic, right? I don't have a stimulus for hypovolemia to turn on that ADH, nor do I have a stimulus for increased serum tonicity to turn on that ADH. So as a result, aldosterone is turned off. There's no reason why aldosterone is on, meaning that I'm going to pee out sodium because I'm not trying to hold on to it. So the main difference between hypovolemic hyponatremia and SIADH is actually the urine sodium, because it reflects the fact that the stimulus for aldosterone is turned on in hypovolemic hyponatremia, and it's not turned on in SIADH. So in SIADH, we know that we're putting out concentrated urine because ADH is turned on. And so my urine osmolality is going to be high. And as you can see, it's the same in both hypovolemia and SIADH. So that brings us to our learning point number 2. And basically, the difference between hypovolemic hyponatremia and SIADH is all about the urine sodium. So in hypovolemic hyponatremia, the urine sodium is low. And in SIADH, the urine sodium is not low because I have no stimulus for aldosterone secretion. Now, in both hypovolemic hyponatremia and SIADH, the stimulus for ADH is turned on. So I'm putting out concentrated urine. My urine osmolality is high. I'd like to take you through a case. I hope that's clear. Are there any questions just before I move on about that? Or you guys are all
I don't see anything in the chat. I think you were pretty clear. I'll let you know if something pops up in the chat though.
Sounds good. Thanks, Anne-Sophie. So I'd like to take you through a case here to illustrate some of these physiologic principles. Now, this is actually a real case I saw in about November at Notre Dame. And it was an elderly Italian lady, Mrs. C. So she was 75 years old. Notably on past medical history, she had high blood pressure, rheumatoid arthritis, a little bit of GERD, and osteoarthritis. She was on methotrexate for rheumatoid arthritis, and she had been started on prednisone, a moderate dose of prednisone, 20 milligrams, that was started over 3 months ago by her rheumatologist at Maisonneuve-Rosemont. And it was started like I said, 3 months ago, and there was no taper initiated, which I was a bit concerned about because you shouldn't have people on that dose of pred for that length of time without a clear plan. She's also on amlodipine for her high blood pressure. Now, she was coming to hospital because it was sort of a vague, just gen det, feeling unwell for about 4 days. She did have decreased PO intake, however, and there was a question of maybe thermodynophagia and the subacute weight loss over the previous several weeks. She was really very euvolemic on physical exam, as far as I could tell. So her sodium was 120, which was why we were consulted. Her potassium was 4.7, creat was 79. She had a mild normocytic anemia, which was not that significant, and everything else was pretty much normal. So essentially, what's the most likely diagnosis here? We can attempt to make this a little bit interactive. I don't know if anyone wants to venture a guess here. What do you guys think the most likely diagnosis is for hyponatremia?
Her SIDH.
Okay, so it could be SIDH. It could be. What else could it be?
Tea and toast.
Okay, good. Anything else?
Hypovolemic.
Yeah, exactly. So I think that's perfect. That's a great differential diagnosis to start with. So essentially starting here, what tests would you like to order?
Urine lights.
Excellent, thank you. Now, the third question here, what management would you like to initiate? Would you like to do anything about this hyponatremia?
She's not quite symptomatic, right? She doesn't have any altered mental status. She's not seizing, and it's probably been there for a while.
Yep.
So I wouldn't jump on it until there's a cause. But you can do restriction, although she's hypovolemic, I'm not sure I would restrict her that much.
Yeah. Does anybody want to give her some volume right off the bat?
I think yes.
You think yes? Okay. Because you think that she could be hypovolemic and that's the cause for hyponatremia.
I mean, if you see that clinically she looks like hypovolemic, you could try giving her a bit of fluid. If she's like very tacky or, I mean, if she looks dry.
Yeah. Okay. I mean, she's not, right? So she's like rock stable. She's rock stable. So good. I think that this is a good starting point for the discussion that I'd like to have with you. So essentially, the key is urine lights. And this is really what I hope that you take away from this, this presentation, that urine lights are really pivotal. We can't understand the cause of hyponatremia or initiate an appropriate management strategy unless we have urine lights. And all too often, what we see on the other side of things in internal medicine is that they're just never asked for. And some management is initiated without necessarily asking for urine lights. And that means that I can't understand what's going on with this patient. I usually just have to stop the management that has been initiated, start from zero, ask for urine lights, and try to work this patient up as if they had just come into the hospital. So I really would hope that you can just ask for urine lights. They're a quick test. They usually take about an hour, 2 hours to come back. They're not expensive and they're very useful. So her urine sodium here was 35 and her urine osmolality was 297. So taking us through what we sort of just learned, with a urine sodium of 35, is the stimulus for aldosterone turned on or off? Does anybody want to venture in a guess here?
It's off as it doesn't reabsorb sodium.
Exactly. So urine sodium is not low. It's not particularly high, but it's not low. Good. Now, what about urine osmolality here? Is she putting out concentrated or dilute urine with a urine osmolality of 297?
Concentrated.
Excellent. So what does that mean? It's a stimulus for ADH on or off?
It would be on.
It would be?
On.
Exactly. So again, antidiuretic hormone. What am I doing? Telling the body not to pee. So I'm holding on to all my free water. So that means that my stimulus for ADH is turned on and putting out concentrated urine. Now the question here, is it appropriate or inappropriate?
Inappropriate.
Good. Why is it inappropriate?
Because the urine sodium is high and the osmolality is high.
Beautiful. So it's inappropriate because I don't have a stimulus for hypovolemia or hypertonicity, right? Because you can see that the urine sodium is not low. Good. So excellent. Well done, guys. So We are in an SIADH kind of situation. We have stimulus for aldosterone is off. We have high urine sodium, and we have concentrated urine being put out. So my stimulus for ADH is on, and here it's inappropriate. So we're essentially dealing with an SIADH. So I'm not going to spend too much time on this because this is something you guys can easily read about, but there's a million causes of SIADH, basically. Pain, nausea, any CNS lesions or tumors, lung lesions or tumors. A patient with just a simple pneumonia can have an SIADH kind of a picture. Stress can do it. And there's about 1 million drugs as well. And if you are questioning a drug that could cause SIADH, just look it up because it may well be the case, because there's many, many drugs that can cause it. Now, in this patient, I won't go into too many details of the internal medicine aspects of this case, but I think for her, she had a lot of pain from this odynophagia that actually ended up being a candidal esophagitis. We scoped her, and it was probably due to the fact that she had been on this sort of moderately high dose of prednisone for about 3 months. And she was not on any gastroprotection. So I think that the pain was a very big stimulus for her. She obviously was not eating that much, but I think it was the lack of serum of solute intake was probably contributing a little bit, but it really was an SIADH kind of a picture. Interestingly enough, I actually diagnosed her with a relative adrenal insufficiency despite taking 20 milligrams of prednisone. It was not enough. Her HbA axis was quite suppressed. If you remember, in the euvolemic hyponatremia category, adrenal insufficiency is actually one of the causes, and it causes sort of an SIADH-like picture. So that was actually the cause of this patient's hyponatremia. We gave her salt tabs, we volume restricted her, and her serum sodium rose to 130, 133 by the time I discharged her. So we did not give her IV fluids. And I'm going to come back to this point in just a second. So she actually comes back, this lady, 2 weeks later with similar symptoms. So decreased energy, low PO intake. And like I said, I discharged her with a sodium of 133. I thought this time she was maybe a little bit hypo to euvolemic, but like I said, the assessment is sometimes a little bit difficult, especially in physical exam. She certainly was not hypervolemic. Her sodium here was 128, so it was better than it was when she first presented to the hospital, but less than it was when she was discharged. Otherwise, her labs were pretty unremarkable. Now, her urine sodium this time was 5, and her urine osmolality was 340. So here, this is now a different kind of a situation. What do you guys think is going on? What's the most likely diagnosis here?
Hypovolemic hyponatremia.
Good. And your management strategy here is, do you want a volume restrictor and give her salt tabs?
No.
No. Do you want to give her Lasix? No. No, you definitely don't.
You want to give her fluids.
You want to give her fluids. Good. But you want to give her fluids because now you have the data to suggest that she's hypovolemic, right? So again, go through this systematically. And I would encourage you guys to really try to go back to first principles when you're interpreting urine lights. Urine sodium is low, stimulus for aldosterone is turned on because I'm holding on to all my sodium. My urine osmolality is high. I'm putting out concentrated urine, which means that my stimulus for ADH is on, like I said, and it's appropriate here because I'm hypovolemic, right? So I want to take you back to the first situation. So the first presentation of this patient, and go through what we see actually is sorry guys, I'm on service here and someone is trying to reach me, but we will have them wait. So essentially, this is a common mistake that we see in the emergency room. So if we go back to the first case, we had a sodium that was quite a bit lower, 120, in a patient who, is not doing well, but is not actively hypotensive or unstable in any way. what we often see is what was raised actually as a management strategy initially. You have a patient coming in with a history that sounds like, hypovolemic hyponatremia. Physical exam is somewhat, not hypervolemic, but hard to differentiate between hypovolemic and euvolemic. And right away, the emergency medicine doctor says, okay, I want to do something because I want to correct that serum sodium, and I think she's hypovolemic. So I'm actually just going to give her a bolus, a liter of NS. And I'm going to do that without confirming what the urine lights are. So what essentially happens here in the first situation, remember it was SIADH, my sodium will go from 120 to 115. Now this happens all the time. I see this probably a few times a month. And often what happens is, the emerge will call you and say, like, I don't really understand what's going on. Why is this patient getting worse, right? And, I typically will say, this is, to me, you're not really improving the patient situation. And as a result, this is going to increase the time the patient's going to spend either in the emergency room or in the hospital. But for me, it's pathognomonic for SIADH. And I want to go through why this is the case. And again, you have to just go back to first principles of physiology here. So in SIADH, the stimulus for ADH is on, but it's on inappropriately. So if I'm going to give a liter bolus, what's going to happen? I'm going to reabsorb a liter of that free water, right? Because my ADH is on, it's going to tell my body, tell my kidneys to hold on to all that free water. And I'm just going to excrete all of the sodium that's in that liter bolus. So as a result, I'm just going to dilute down my serum sodium, and that's going to decrease my serum sodium. So I'm going to become even more hyponatremic. So I would caution you to order urine lights before giving volume. Because like I said, they're cheap, they're easy to get, they don't take that long, and they're pretty important in understanding the cause of hyponatremia. Now, obviously there's an exception here, as was raised by one of you guys before. In patients who are unstable, I really don't care what the serum sodium is. I'll deal with it later. So essentially, treat unstable patients regardless of the consequences to their serum sodium. Give them volume if you think that they are hypoperfusing. But in a patient like the one I'm presenting, she's stable. Like Anne-Sophie mentioned, it's probably chronic. We can wait the 2 hours to get my urine lights before initiating any management. There's really no reason to be rushing through this. So that would be my message to you, to try to avoid this mistake. So learning point number 3, if you treat SIADH like hypovolemic hyponatremia, you will decrease the serum sodium when you give them volume. So try and make an effort to order urine lights. So when to consult internal medicine? So essentially, this is a good question, and it's always going to be a little bit of a case by case. But I'll try to give you some guiding principles here. So when we talk about hyponatremia, we need to think about the severity of hyponatremia, because that comes into play when we want to, when we're considering consulting another service, right? So typically you're going to read different things, but mild hyponatremia, this is up to date, talks about, a sodium of about 130 to 134, moderate hyponatremia 120 to 129, and severe is less than 120. For the most part, I pretty much agree with that. Now, the key here is we're essentially just trying to avoid complications of the hyponatremia, right? And the complications that we're worried about are the neurologic complications, right? So the risk of seizures and neurological manifestations. I thought this was interesting. A study that actually looked at the amount of seizures we see depending on the serum sodium. So as you see here, as the serum sodium becomes lower and lower, the risk of seizures goes up to 10%. So 1 in 10 patients with a serum sodium less than 110 will seize. Only 2.5% with the serum sodium of less than 120, let's say, will seize. But that number increases quite dramatically, almost doubles as you drive your serum sodium down by 5 points. So I think that's something to keep in mind. The other thing to keep in mind is whether or not it's acute versus chronic. Now, why do we care about this? Acute, we usually say, is less than 48 hours, chronic over 48 hours. Now, they're both important, but in different ways. So in acute hyponatremia, there's a greater risk of complications as you drive your serum sodium down acutely. So we're talking about cerebral edema and seizures. And as a result, you need for aggressive therapy with close monitoring, because if my serum sodium goes from 125 to 115, the brain doesn't like that. So you kind of need to pay attention to that and manage that more acutely. The chronic hyponatremias, I'm less concerned about the effect on their brain and the symptoms that they might have acutely, but I'm more concerned about the correction. Because there's a higher risk of complications from overaggressive therapy. And as a result, there's the greater need to monitor these patients to avoid overcorrection. Now, the problem is we often don't know unless you have labs from a week ago or a day before the patient presents that's showing what their serum sodium is. It's a little bit hard to know if it's acute or chronic. So for the most part, we generally take a fairly measured approach, and we're careful not to avoid overcorrection. Yeah, so that's something to keep in mind. So, when to consult IM? Again, you're trying to identify those who are at higher risk for complications from untreated hyponatremia or from overcorrection. I would say definitely with a serum sodium of less than 120. I think that's appropriate. I think, again, the acute versus chronic. Acute, you really want to kind of bring that serum sodium up in a way that's safe but appropriate. And when they're chronic, you want to just monitor them a little bit more closely to make sure that you're avoiding overcorrection, because the danger of overcorrecting sodium, as you know, is something that's completely iatrogenic and avoidable, and that's central pontine demyelinosis. And that causes a locked-in kind of a syndrome. And it's just really very terrible, and it's totally iatrogenic and avoidable. So you want to be quite conscious of that. I would say there's a gray zone with a serum sodium between 120 and 130. I might be a little bit more trigger happy to consult, or be happy at least as a consultant to get these requests if it's acute, because then I really do need to come in and figure out what's going on and raise that serum sodium in an appropriate way. I'm less concerned if it's chronic, especially if it's like 126 and chronic. But if it's 125 and chronic, you may want to get us involved, and that's okay, because these kinds of patients need timely follow-up. Having said that, I saw a patient a couple of days ago who I discharged with a sodium of 126, and she's just been hanging out at 125, 126. So that didn't really worry me. But I still wanted to make sure that she had close follow-up. And arrange to see her the following week to make sure that she's not overcorrecting too much with the management strategy that I put in place. So ultimately, it's a little bit of it depends a little bit on the situation, but I hope that gives you some overall ideas as to when we like to be consulted for these kinds of patients. So that's kind of all that I have for you today. In terms of some learning points. So again, aldosterone affects urine sodium. So when it's on, urine sodium is low. ADH affects urine osmolality. When it's on, urine is concentrated. So my urine osmolality is high. The main difference between hypovolemic hyponatremia and SIADH is the urine sodium. And that essentially tells you if your stimulus for ADH is appropriate or inappropriate. Treating SIADH, like hypovolemic hyponatremia, will decrease your serum sodium. So try to avoid doing that unless you have to, unless your patient is unstable, and see if you can just order urine lights before you initiate a bolus. And general parameters to consult us. So the lower the serum sodium, the higher the risk of complications. The more acute, the higher the risk of complications if you don't correct it acutely. But on the chronic side, the more risk of complications if you overcorrect. So generally speaking, if the serum sodium is, the lower the serum sodium, we want to be involved, especially if it's less than 120. And if it's acute versus chronic, as we mentioned. A couple of references, but this is mostly my brain and mostly, being an internist and trying to understand this for the first 3 years of my residency. If you have any questions, I'm happy to answer.
I love that this is mostly my brain. We have a question from Dr. Bake. Let me just find it here. He's saying, sorry if I missed it, but can you comment on interpreting urine lights in the patient on diuretics?
Interpreting urine lights on the patient, yeah. So that's it's a good question. Essentially, what does Lasix do? It makes you pee out sodium. So if you're going to pee out sodium, then essentially your urine sodium is going to be affected, and you're peeing out sodium, and you're also peeing out dilute urine, right? So your ADH is also going to your interpretation of your urine osmolality is going to be a little bit affected. Having said that, you can still order them if you think your patient's hypovolemic. The stimulus for hypovolemia might be stronger than the effect of the diuretic. So if your urine sodium is low, you can kind of say that this is maybe a reason for, you might actually have a hypovolemic situation even in a patient who's on diuretics. But if your urine sodium is not low, I'm not necessarily sure what to make of that. So I think it's still useful, but you just have to, I think, put an extra layer of thought into what you do with that.
Great, thanks. I also have a question on the mild hyponatremia and DED management. So, I mean, I think you've hammered down the point really clearly. Please order the urine lights. I think that was made very clear. That being said, let's say that you have what appears to be an acute hyponatremia that's very 131 sodium. Would you still want to order the urine lights? Because I've had different staff telling me different things in the ED, but is it still useful, or would you, because it's not something we're necessarily going to consult internal medicine on, would it be okay to wait and not do anything about them? And
I mean, 131, I don't really care that much, to be honest. I think the risks are pretty low. But you know, there's the question, what's going on, right? I don't think you're wrong in ordering the urine lights. It gives you an idea of the physiology here. I mean, if you're thinking the patient might be a bit hypovolemic, the urine lights will actually confirm that diagnosis for you, because if your urine sodium is low, you know that the stimulus for aldosterone is present, right? So it might just reinforce, you know, the idea that you want to give volume, that you're on the right path, right? So I don't think it's wrong to ever order urine lights, because like I said, they're cheap and they're easy. And it gives you an idea of what's going on with the physiology. Now at 131, like I said, do I really care? Probably not really. The complications are not that significant. But I think it might just give you a bit of a leg up as to the diagnosis.
you correctly identified the underlying question is how much do you care about a sodium of 131? We have
not that much. I mean, yeah, and again, like maybe you ask 3 different staff what they think, and they might have, you know, different answers. But to me, I think the literature is fairly clear that as you drive your serum sodium down, it's really less than 120, and especially less than 110 that I'm much more concerned about. And like the 120 to 130, it's a bit of a gray zone. I don't really like a sodium 122, 125. I mean, that's abnormal, and it's reasonable to understand what's going on. But the risk of complications, I think, are not that high.
Fair. And the last, Antoine is asking, how would you treat a neurosymptomatic SIDH if you cannot give IV fluid?
Sorry, a symptomatic SIDH?
Yeah,
Well,
so
like
how would you treat?
that would
Yeah,
be
go ahead, Antoine.
Symptomatic, considering he's got hyponatremia because of SIDH.
Okay, so I think that's a good question. I didn't talk about management here, but I'm happy to come back and give you a talk about that. So essentially, the management of hyponatremia is actually quite simple, especially in the acute phase. As soon as the patient is symptomatic, so if they're showing any kind of neurologic manifestations, if they have a seizure, if they're confused, the answer right away is give them 3%. You're not going to be wrong. However, it's not dependent on the degree of hyponatremia. I've seen patients hanging out with a serum sodium of 105, and they're not really symptomatic. So I'm not really going to rush to give 3%. There's not a clear indication to do so. So if you have a patient who's coming in with a sodium of 105 and who's seizing, you give them 3%, hands down. It doesn't really matter what the cause is, because you need to raise that serum sodium to a point where the brain is not going to seize. So you give them 3%. Now, in an SIADH, you're never going to want to give them volume, right? Unless they're hypovolemic, or let me actually rephrase that. In a patient who has SIADH, you're only going to give them volume volume if they have an indication to give volume because they're septic or for another reason, right? So you're never actually going to give, that's not the treatment for SIADH, it's not giving volume, it's actually volume restriction and salt tabs, right? Plus or minus some Lasix potentially, if you really need to raise that serum sodium. So in a patient who's symptomatic, who has SIADH, you give them 3%. Does that answer the question?
Okay, so that they are still able to reabsorb some part of the sodium, basically. Even though we say aldosterone is off, they can still retain some sodium.
So with SIADH, aldosterone is on, right? Sorry, ADH is on inappropriately. Aldosterone is not on, right? So they will eventually. I see the question, and you will. The 3% will work.
Okay.
Will reabsorb
and some of it will get absorbed.
Yes. Yes.
Okay.
So I think there's a hand raised. Rachel, I hear your phone ringing. I know you're on. So we're going to try to, there's just one question, maybe a quick one, an extra like 1 minute.
Yeah, no problem. No problem.
Who's JC?
It's me. And so it's Gemma.
Hi, Gemma. Go for it.
Hi. So
1 minute.
hi there. Thank you for the fantastic talk. I just had a quick question. For the patient who has a sodium of say 128, 129, asymptomatic, but older, not a great history, not great social supports, no family doc, my reason for consulting internal would be more because I'm concerned about dispositioning that patient home without solid follow-up. Would you prefer us to, or would you say it's reasonable to rather just arrange like internal med clinic instead of asking you to come see her in the ED?
Yeah, I mean, so it's a gray, it's a bit of a gray zone. Unfortunately, the NUHC, there's not a great setup for quick follow-up, right? Really
Exactly.
what you need is a rapid access clinic. So
Exactly.
Where I work most of the time at Notre Dame, we have a day hospital, so I can easily see patients a week later with lab support with the nurses. So it's easier for me to arrange that kind of follow-up. But at the NUHC, it's a bit harder. I don't think it's wrong to order the urine lights and send them to the internal medicine clinic if they're really asymptomatic from it and you think it's chronic. Having said that, I think it's probably a good idea to have an idea as to what's going on. Like if you think this patient has a hyponatremia because of SIADH, it would be important to initiate a workup. If you don't have a clear reason, meds, pain, a pneumonia for the SIADH, you always have to worry about malignancy. So, if you think that patient might be going down that category, obviously, and that's kind of the reason why they're not doing well, then I think it's reasonable to get us involved, in hospital, even though that patient doesn't need to stay, just to initiate some of the imaging and management strategies that we do to confirm the SIADH and the potential cause for it. If it's just a patient's not really eating that much, maybe a bit tea and toasty, then I think it's probably reasonable to order the urine lights and send them to internal medicine in clinic. It's a little bit hard, obviously, to say don't consult us because it's hard to say what the situation is, but I don't know. I hope that gives you a bit of an idea as to how we see things from our perspective. It's a bit of a hard question for me to be able to answer decisively.
Yeah, for sure. That's helpful.
Thank you so much, Rachel, for being here today. We really appreciate it. And I know you were on call and getting called at the same time. Really appreciate your presence here. Thank you so much. Don't be sorry. We're sorry. Thank you.
All right. Bye, guys.
Okay. All right. So swapping in and out with Anne-Sophie. Okay. So great lecture so far this morning, and we're going to move on. We are a bit over time, but we'll correct that with the break coming up after Marta's talk, which is on the subject, should we be giving TXA to everyone walking down the street or not?
So I'm just going to share my screen. Can you guys see what I see? And then.
Yeah, it's in presenter mode, or sorry, it's full screen rather. Like it looks good.
Okay, amazing. So hi everyone. For those who I haven't had the pleasure of working with or meeting, I'm Marta. I'm one of the CCF PEM residents this year. And for my critical appraisal topic, I'll be talking about the use of tranexamic acid in the eMERGE and the different indications. So the way I set up my lecture is obviously TXA is used for many different pathologies in the ER, but in the interest of time, I decided to focus on 4. So we're going to start off with a few quick case presentations, and you can sort of think to yourself or maybe mention in the chat if you have a tendency to use TXA in these patients or not. Then we're going to quickly review the history of TXA. And then the 4 pathologies I decided to review are PPH, hemoptysis, epistaxis, and GI bleed. And I'll be presenting one article for each, which is the best evidenced article at this time for these presentations. And then the conclusions and a bit of what I learned throughout the research that I was doing. So if we start off with a quick case, the first one is you're working in a rural emergency department when a 27-year-old female G1 who's 37 weeks pregnant comes in after spontaneous rupture of membrane fully dilated. So you end up successfully delivering the baby, which is the hardest part. But 5 minutes after delivering her placenta, you begin to see that she has a moderate amount of vaginal bleeding. So is this someone that you would consider giving TXA to or not? Do you guys see, by the way, like the Zoom chat on the side, or no? You just see my PowerPoint?
I can see the Zoom chat. Yeah.
Just
I'm not sure if you are able to, but.
Okay, sounds good. The second case is a 65-year-old man. He has a history of recurrent anterior nosebleeds, and he's on Plavix. He comes to your emerge after bleeding from his left nostril after picking at his nose. He's hemodynamically stable, and he's been applying direct pressure for 10 minutes properly. Is this someone that you would give TXA to or not? The third case is a 74-year-old male. He's previously known for COPD, CAD, and atrial fibrillation on Eliquis. He comes in with a 1-day history of minor hemoptysis. He's hemodynamically stable, but on exam, you clearly objectify that he's been coughing up blood. Is this someone you would give TXA to or not? And the final case is a 41-year-old male. He's known for alcohol use disorder. He's a cirrhotic with a history of variceal bleeds. So he comes in with a 3-hour history of hematemesis, and he's unstable at triage, being hypotensive and tachycardic. Is this someone you would give TXA to or not? So you guys can sort of keep these 4 cases in your mind as we sort of progress through the different trials and studies. If I give you guys a bit of information on TXA, so it was first discovered in the 1960s in Japan by a husband and wife doctor duo who had the desire to decrease the incidence of PPH in Japan after the Second World War. It was initially approved by the FDA mostly for women with menorrhagia or patients with hemophilia. It's quite an attractive drug for us for many reasons, and one of which is it comes in very different forms. So we have IV, PO, topical formulations, which include nebulized forms as well. In terms of how it functions, so essentially it binds to plasminogen in order to prevent its conversion to plasmin and therefore eventually prevent the degradation of the fibrin meshwork that's created by the coagulation cascade. So the first presentation we're going to discuss today is postpartum hemorrhage. So as defined by the SOGC, postpartum hemorrhage is defined as more than 500 milliliters of estimated blood loss after a vaginal delivery or 1,000 milliliters of blood loss after a cesarean section. It's the leading cause of maternal deaths worldwide, and it particularly affects countries of low and moderate income backgrounds. And the thought process of using TXA in postpartum hemorrhage was actually inspired by its use in trauma after the crash trials. So they saw in trauma that there was early activation of fibrinolysis in these patients, and studies have shown that childbirth sort of results in the same thing. So if it helped the trauma patients, maybe it can help women in childbirth. So the trial I present to you guys today is the Women trial, which is a very popular one in the OBGYN literature. So it's a randomized double-blind placebo-controlled trial that took place between March 2010 and April 2016. It was a very large study, including 21 countries and 193 hospitals, particularly those in developing countries. In terms of who they included in the study, so they had women over the age of 16 that had a PPH, which was defined by the delivering clinician. And it's unclear, basically the clinician had to be uncertain about whether he should give this patient TXA or not. So how it worked, so I'm going to come back to it later, but when they first started the study, their primary outcome was basically to see what would be the effect of TXA on all-cause mortality or hysterectomy within 42 days of randomization. This was later changed or revised to look at death from postpartum hemorrhage. What they did is once the patient was decided to be included in the trial, they would give 1 gram of IV TXA over 10 minutes versus the equivalent dose in placebo. They could repeat the dose if ever the bleeding did not stop after 30 minutes or if there was recurrence within 24 hours. Secondary outcomes included thromboembolic events, surgical interventions, any signs of end organ damage, and effect on quality of life. The way they justify changing their primary outcome is that they realized about almost 6 months before the trial was over that the decision for hysterectomy was made at time of randomization or slightly prior. So it was impossible for TXA to have an effect on that outcome, which is why they revised their outcome to death from PPH. So if we actually look at the results, it was a huge trial. It included 15,000 women and then was eventually increased to 20,000 women because they wanted to dilute the effect of the women who were picked to have a hysterectomy at time of randomization. They had 483 maternal deaths, with 77% being within 24 hours, 9% within the first hour, and 72% of the deaths were due to bleeding, with over 25% having non-bleeding causes of their death. The groups were both comparable in terms of their baseline characteristics. So things from age, causes of PPH, whether it was a vaginal or cesarean section, and time to TXA were equal between both groups. So if we look at their results, so if we look at their original primary outcome, which was all-cause mortality and hysterectomy at 42 days, there was actually no statistical difference, with the TXA group having 5.3% and the placebo group having 5.5%. If you look at their revised primary outcome, which was death from PPH, there was actually statistically significant decrease, with a decrease in the TXA group by 0.4%, with a number needed to treat of 267. In terms of their secondary outcome, there was actually no difference in risk due to bleeding when TXA was given after 3 hours, and there was no statistically significant difference in terms of thromboembolic events, death from other causes, or quality of life. The only positive secondary outcome was that women who received TXA were more likely to have brace sutures as opposed to laparotomy. So if we discuss maybe the strengths and limitations of this trial, it's quite interesting because when you read about this trial in the obs-gyn literature, it's seen as a very positive trial, while the ER literature is actually more critical. So if we look at the strengths, it's obviously a very clinically relevant question. It's a large multi-center study. The randomization and blinding were done appropriately, and they had similar patient characteristics between the groups. They had excellent follow-up, so only 33 patients were lost to follow-up in the over 20,000 that were randomized. In terms of limitations, so the study does have quite a few limitations. First and foremost, there were a lot of clinical decisions that were quite subjective. So initially, just to be included into the trial, there had to be uncertainty among the clinicians as to whether the patient would benefit from TXA or not. The second issue is estimated blood loss. So this is a approximation. It's just a measure that the clinician sort of a number that they feel is appropriate, which obviously we're not great at. And the other indication is they define PPH as enough blood loss to cause hemodynamic instability without predefining what hemodynamic instability is. The other thing is they changed their primary endpoint 6 months before the end of the trial, which is always a concern. They changed it to disease-specific mortality. So instead of looking at all-cause mortality, they looked at death from PPH. So that sort of triggers the debate about the significance of disease-specific mortality, given, first of all, it's a subjective measure, right? So the cause of death is what the clinician writes on the death certificate. We can always have a strong inclination of why the patient died, but it's never an exact science. And then second of all, there was no change in all-cause mortality. So if essentially the patient is not going to die, that's sort of our concern. And then the other point is if they're going to die from PPH, but we tell that they're not going to die from PPH, they can still die from something else. So in real life, is this really relevant? The final point is they sort of justify changing their endpoint by saying that over one quarter of the women died from causes that were not due to bleeding. So to be able to see an effect on all-cause mortality, they would need a trial that's much larger. They had a large number needed to treat as well. A lot of these studies were done in developing countries, so maybe they have different resources than what we have access to in North America. And then finally, it was the IV route that was studied. A lot of these women in developing countries end up dying at home from their PPH. So it would have been interesting to see the use of TXA via other routes that are maybe more accessible compared to the hospital setting. So if you look at the clinical bottom line, when you finish reading the study, the author's conclusion, they actually start off with their secondary outcome. So they don't mention all-cause mortality or hysterectomy until later on. And their conclusion was that TXA reduces death due to bleeding in women with PPH with no adverse effects. When it's used as a treatment for PPH, it should be given as soon as possible after bleeding onset. So what I learned is that it can be beneficial. Obviously, we have to take the limitations of the study into consideration. The TXA usually has a good safety profile. It's not expensive, and it had no adverse effects in this trial. So it favors its use in patients that are critically ill. And if it's used, it should be given early, as there was no statistically significant difference after 3 hours. As a final note, it's actually pretty interesting to note that the SOGC does not include TXA in its guidelines for PPH management, as opposed to the ACOG, which does as a level B recommendation. So we're going to move on to epistaxis. So obviously epistaxis is a very common ER presentation. We have many measures that are offered to us, which include like holding pressure, using local vasoconstrictors, topical application of silver nitrate, and packing. Packing for patients can be uncomfortable, and it always requires a follow-up visit as well. Prior studies before the one that I'm going to present to you today did show some possible evidence for TXA and epistaxis in reducing risk of rebleeding. So the trial I present to you guys is the NOPAC trial, which is an RCT, and it's by far the largest trial to study the effectiveness of TXA for this indication. So it's a randomized, double-blind, parallel group, placebo-controlled study that took place between May 2017 and March 2019 in 26 centers in the UK. They basically included patients over the age of 18 with epistaxis that was refractory to initial measures. They had multiple exclusion criteria, which included anyone with any hemodynamic instability, any patients with a known ENT malignancy, any coagulopathic patients, any hemophilia patients, and any pregnant patients. So essentially, these are your sort of walk-in patients that are not critically ill. So in terms of the trial itself, the primary outcome was to see if there was any difference in use of anterior nasal packing during the index ER visit. So this is different than prior studies that looked at TXA and epistaxis, because their outcome was not to look at risk of rebleeding, but more whether anterior nasal packing was required. Their secondary outcomes included admission, need of transfusion, whether there was recurrence, whether there were any thromboembolic events, or reattendance within a week. So how the trial was done is once the patient would come into the emerge with epistaxis, they had to have had applied pressure for at least 10 minutes. And if they were refractory to that, they would then get a topical vasoconstrictor. In this case, they used phenylephrine for at least 10 minutes. If that didn't function, then they were randomized into either the topical TXA group or the sterile water group. If they were in the TXA group, it was 200 milligrams in 2 ml, which were applied to a cotton wool dental roll for at least 10 minutes versus the equivalent in sterile water. They can repeat the dose at least once. So in terms of the results, they had 496 patients that were enrolled in the study, with over 800 that were excluded. The mean age was 70, with an equal division among females and males. 69% of the placebo group and 61% of the TXA group were anticoagulated. So in terms of their primary outcome, which was requirement for packing, they had no statistical significance. So 41.3% in the placebo group and 43.7% in the TXA group. And they also had no statistical significant differences in secondary outcomes, which included need for admission, need for PRVCs, and recurrence of the bleed. So in terms of strength and limitations for this study, so strength, again, it's a clinically relevant question. It's the largest study up to date to investigate the role of TXA, and more specifically topical TXA, as an adjunct to standard therapy. The randomization was done well, it was double blinded, and the primary outcome was evaluated in 100% of the patients. The limitations, it was a convenient sample. So as I mentioned before, they had over 800 patients that were excluded due to lack of nursing and staff required to put them in the study. They also estimated that 95% of the patients would require anterior packing for their power calculation, but the number was far less, so they could have missed a few nuances in terms of statistically significant differences. The choice of vasoconstrictor was phenylephrine. In North America, oxymetazoline is actually more often used, so that could have been a bit of a difference. I put this in admission in limitations, but it's more of an observation. They had an extremely high admission rate of 44%, which is not the numbers we see in our like in the emerges we work in, and that's more of a cultural thing. So the UK is more likely to admit epistaxis, as well as the fact that they have a 4-hour rule where a patient ideally should be admitted within 4 hours of arrival to emerge. They did not distinguish between anterior and posterior bleeds, which differentiates this study from prior studies. So obviously it's not a diagnosis we often have while we see the patient, but if there were more posterior bleeds, they would be more likely to be refractory to some of our initial measures. So in terms of the conclusion and the clinical bottom line, so the author's conclusion basically states that in a patient presenting to the ED with atraumatic epistaxis that is uncontrolled with simple first aid measures, topical TXA applied in the bleeding nostril on a dental roll is no more effective than placebo at controlling bleeding and reducing need for packing. So what I learned is a bit of the same thing. It's lack of evidence to demonstrate the worthy use of topical TXA in epistaxis. What's interesting is sterile water actually outperformed. It prevented 55% of these patients from anterior packing. So maybe we should be using a bit more water on our cotton wool to try to avoid packing in these patients. Okay, next is hemoptysis. So this was the third case I presented. So hemoptysis is obviously a very difficult presentation for us because we often are limited in terms of definite treatment for these patients because a lot of what they need goes beyond the scope of most ER physicians. So they often need either intervention, bronchoscopy, IR, or OR. So there's no real medical therapy for the ED that we can offer these patients, except for maybe antibiotics for infection. And from the 4 presentations that I'm discussing today, this is by far the one that has the least quality evidence, the smallest studies, and not much really in terms of guidelines. So the best I can find for today was an RCT by Wand and his team that basically wanted to look at the use of nebulized TXA for non-massive hemoptysis. This was a prospective double-blind placebo-controlled randomized trial that included patients over the age of 18 that were admitted to a chest ward after developing hemoptysis in the last 24 hours. So this was not an ER-based study. These were patients that were already admitted to the hospital. They had multiple exclusion criteria. So similar to the NOPAC trial, these were not sick patients. These were any patients who were massive hemoptysis or who were hemodynamically unstable or had any respiratory instability or coagulopathy, liver failure, renal failure were not included in this study. So what their question were, so they had 2 primary outcomes. The first one was rate of complete resolution of hemoptysis during first 5 days from admission. And the second one was difference in daily volume of expectorated blood. Their secondary outcomes included rate of procedures, so requirements for bronchoscopy, angio, or surgery, and length of stay in the hospital. So once the patient was decided to be entered into the study, they basically gave them either inhaled TXA, so 500 milligrams per 5 ml TID, so in nebulized form, versus the equivalent in placebo, which was nebulized NS. So if we look at their results, their study was much smaller than the ones for epistaxis and postpartum hemorrhage. So they only had 47 patients that were randomized with a mean age of 66, with a good majority being males and a good amount being smokers and those with lung disease. They had over 50% that were anticoagulated. The groups had a good amount as well of lung malignancies. So if we actually look at their results, so in terms of their primary outcomes, so the first one, which was a reduction in bleeding at 5 days, 96% of the TXA group stopped bleeding by day 5 compared to the placebo group, which was only 50%. In terms of blood volume, so they had decrease of a daily blood volume in the TXA group, so 15 cc's per 24 hours versus the placebo group, which was 50 cc's in 24 hours. And this was by day 2 of admission. They had no adverse events, and they did have decreased mortality in the TXA group at 0% versus 9% in the placebo group, but this was not statistically significant. It evened out at 1 year. So those are the results and a bit of the graphs that we can see. So in terms of the strengths and limitations of this study, so obviously it's the first study to assess the effectiveness of nebulized TXA on hemoptysis, as opposed to the PPH study where the EBL was an estimation. They had objectified the blood loss here by using measured cups, so that always helps. They had balanced group in terms of clinical characteristics and causes of hemoptysis, but it's important to note that these were very small groups. So if the study were to be continued on larger groups, these may have been eventually been significant. In terms of limitations, so sick patients were not included in this study. As we saw, these were very hemodynamically stable patients. This was a very small study. They only had 47 patients that were randomized. It was a single center. And it's unclear when the patients improved. So we saw by day 2, they had decreased volume of blood loss. But in the emerge, I guess our concern is more like, should we expect changes within a couple of minutes, within a couple of hours? So is this really applicable to ER? And it's unclear why the study was stopped early. So in order to reach statistical significance, they would have needed 60 patients, but they stopped at 47. So that sort of, how do I say, sort of limits how much we can interpret from the study. So in terms of the clinical bottom line, the author's conclusion was that nebulized TXA can be used safely and effectively to control bleeding in patients with non-massive hemoptysis. What I learned, so the study is a small one, but it does show some positive potential use of nebulized TXA in these non-massive cases. And obviously these are patients that we are sort of limited in what we can offer. So if there is some benefit with no adverse effect, I think it's something to consider to use in our practice. It's unclear if this would be relevant for us just because of the timing of improvement. So maybe these patients will improve during their admission and not necessarily when we see them in the emerge. And this study, to sort of bring the point that it was not for sick patients. So we can't sort of use this and apply these to sicker, more unstable patients. So the final one is GI bleed. So this is the initial indication that made me look at TXA before I sort of decided to broaden my talk. I don't think GI bleeds need much of an introduction, but it's a common cause of death worldwide. Upper GI bleeds are more common than lower GI bleeds, with a case fatality of 10% in upper GI bleeds and 3% in lower GI bleeds. Many patients rebleed after we initially see them in the initial hemostasis, and this increases their risk of death by 4 times. So the question is, can TXA help these patients or not? So the trial I present to you guys is the HALTED trial, which has been a very popular trial within the emerge literature since it was released in the Lancet in June of 2020. It's an international multi-center randomized placebo-controlled trial that took place in 164 hospitals and 15 countries. So it was a very large study. It took place between July 2013 and June 2019. In terms of the inclusion criteria, so any patient with significant upper or lower GI bleed that was an adult in their home country, so 16 or 18, significant was defined as a risk of bleeding to death. So these were, as opposed to the prior studies, very sick patients. So hypotensive, tachycardic, signs of shock, or any patients that the clinician thought would probably need a transfusion or urgent endoscopy or surgery. In terms of their outcomes, so this is a study that also changed their primary outcome, but I'm going to mention that a bit later on. But ultimately, what they were looking at was death due to bleeding within 5 days of randomization when comparing TXA to placebo. Secondary outcomes was death within 24 hours to 28 days, all-cause mortality at 28 days, risk of rebleeding, need of transfusion, thromboembolic events, medical complications, and length of stay in the hospital, which was both ICU and the ward. In terms of the dose that they gave, so compared to prior studies, they gave an increased dose of TXA. So the loading dose was 1 gram IV of TXA over 10 minutes, and then they got basically the equivalent of 3 grams over 24 hours at maintenance dosing versus placebo, which was at the equivalent dose. The way they justified how they gave their dosing was that TXA has a half-life of about 2 hours. So the risk of rebleeding is the largest in the first 24 hours. So they wanted to make sure that they were covering these patients during their period of increased risk of rebleeding. So if you look at their trial, it's a pretty large one as well. 12,000 patients were randomized with a mean age of 58. 9 in 10 patients had an upper GI bleed, with 50% having suspected variceal bleeding. Most of them were liver disease patients, but only 9% were actually anticoagulated. When we read about TXA a lot, there's this 3-hour window that was sort of inspired from the crash trials. So here, only 16% of patients actually presented within 3 hours of bleeding. The average was actually 22 hours between bleeding onset and receiving the TXA. So if we look at their results, the primary outcome, there was no change in death due to bleeding at 5 days. So you had 2.1% in the TXA group and 2% in the placebo group. They also had no difference in death due to bleeding or rebleeding at different time points. So they looked at 24 hours, they looked at 5 days, they looked at 28 days, and then they looked at rebleeding at those intervals, and there was no change at that time too. As opposed to the women trial, where there was a change in outcome and they didn't really discuss all-cause mortality at the end, here they looked at all-cause mortality at 28 days and there was no difference as well. Finally, there was no difference in any of the subgroups of the primary outcome. So they looked at if there was a difference in terms of time of onset of bleeding, bleeding location, if it was whether it was variceal or liver, and there was no change in that as well. In terms of secondary outcomes, it's important to note that they did have adverse events with doubling of the VTE risk, 0.8% in the TXA group and 0.4% in the placebo group, with a number needed to harm of 250. And this was more pronounced in patients with variceal bleeds. So the halted trial, if we look at the strengths and limitations, so obviously it's a very large trial assessing the need for TXA in GI bleeds. They had balanced group, they had excellent follow-up, and it included patients with a wide range of clinical presentations from melena to hematemesis to hemodynamic instability. The limitations, so just like the women trial, their primary outcome changed halfway through. The way they justified it is that they realized as the study was progressing that over half of their patients were dying from causes that were different, that were other than bleeding, and therefore they didn't expect to see a change in all-cause mortality. And because they were being inspired by the women trial that was released and the crash trials, they didn't expect to have an effect on all-cause mortality. What's great about this study, though, is that they still looked at all-cause mortality at 28 days, and there was no change either. And they sort of justified that in their discussion. The majority of their patients had variceal bleed. So if we're working in a population that is less likely to have this as a cause of their bleeding, it's something to take into consideration. They only had 9% of patients that were anticoagulated. So it's important to sort of think about that in our patients that are on anticoagulants. And a lot of them were late presenters. So the average time of difference was about 22 hours. The question is whether these patients, if they would have presented earlier, would they have benefit from the TXA? GI bleeds are different than other causes for TXA, other reasons for TXA use, because the patient could have had occult bleeding before they had the massive bleed that caused them to come in. So it's a bit more different. And as I mentioned before, this is disease-specific mortality. So the significance of that in a clinical setting is always difficult. So if we finish with the author's conclusion, so they found that TXA did not reduce death from GI bleeding. On the basis of their results, TXA should not be used for the treatment of GI bleeding outside of the context of a randomized trial. What I learned, so there's no evidence for TXA use in GI bleeds, and they did have an increase of VTE risk, especially in patients with known liver disease who have decreased fibrinolysis, and therefore at baseline will probably have a bigger thromboembolic risk. So I just added this here because I thought Rebel EM had a really great graph that sort of highlighted this study. And you guys can sort of look at it or review it on their website because I thought it was great. So in terms of conclusion for my cat, so it's a TXA is a popular drug. It can be used in a wide array of clinical presentations, specifically in the eMERGE. Positive findings for TXA use in bleeds are often smaller, lower quality studies, as we saw with the hemoptysis study, while larger studies and higher quality studies tend to have negative findings, like the HALTED trial, the NOPAC trial, and then you have equivocal ones like the women trial who show potential benefit. Obviously, we would love to replicate these studies at larger scale so that they can really be practiced and clinically changing. We should know the evidence behind the use of the TXA and potential harms, especially in adverse events when it comes to things like a VTE risk. And we should know which populations were studied in these trials so that we're able to apply them to the correct patients when they come to us in the eMERGE. That's pretty much it. I don't know if there were any questions or comments.
Hi, Martha. Actually, I was wondering for the first trial you presented, did they include patient regardless of the cause of PPH? Because obviously a laceration versus atonic uterus. And then I'm kind of wondering what to do with use of other meds if they used oxytocin or such.
Yeah, so they
like what kind of conclusion we can draw from this?
Yeah, so they actually did divide the patients in terms of regardless of the cause. So whether it was uterine atony, whether it was lacerations, and they saw that there was really no there was no difference among the groups in terms of their characteristics, and they didn't really look to differentiate the cause of the PPH. It was just whether clinically they had a PPH or not. I don't know if that answers your question.
Yes, thank you.
I think there may be another question. How will you change your current practice in the context of what? I think the question sort of cut off, but how will I change my practice? I mean, I think for the higher quality studies, in terms of the HALTED trial, if we're talking about that specifically, there's really no, I wouldn't consider using TXA for that indication. I think for patients with hemoptysis, it really made me consider adding it on, given that there could be some benefit and we don't have much we can offer these patients before they do get their definite treatment. In terms of epistaxis as well, I think it was enough of a quality study where we consider not using it because there really was no benefit. And in terms of postpartum hemorrhage, the ACOG has it as a level B evidence. So if it were a patient that I did have and that I had thrown the kitchen sink at, I think I would consider adding it on if I did not have a response. So I think the women trial, the NOPAC trial, and the HALTED trial were all good quality studies. The one for hemoptysis was a bit lesser quality, but I think for these patients, because we don't have much, we can also consider giving them some TXA.
Awesome. Okay.
Yeah.
Yeah, no, that was a great review just of these common presentations and what is preferable in terms of what we can use. So thank you so much for that. It was a great review. Okay, so it's been a great morning so far. We are over time a fair amount, so I still think we can use a break. So let's come back at 10:10 and we'll see if we can make up time as we go for the second half of rounds. So 10:10 we'll come back.
So just to make sure you guys can see my screen.
Yeah, we got you. All right, so we're back. It's 10:10. So three cool dudes are going to present to us now about an ECG algorithm for acute MI and left bundle branch block. So go for it, guys.
Nick, did you want to start or?
Nick,
Nick.
Oh no, hopefully he's not lagging here.
yesterday during our run test, his internet had a hard time, so we'll see.
Can I see your electrocardiogram right now?
Maybe we can at least like just start with presenting what the paper is, and then when we get to more of the method section, Nick can hopefully work it out by then. So let's see, we'll see what happens. All right, so we can just start off. So to just start journal club. Wait, does Nick work?
Everyone. Yes, I'm back. I don't know what was wrong.
You're up, Nick.
Oh, okay. I didn't hear anything you said until the last like 2 words you said, but I guess we're starting. Okay. Hey guys, this is our journal club, Johan, Antoine, and I. And we're going to be presenting a nice paper for you guys today. The title of said paper is, oh, what's going on, Johan? There we go. New electrocardiographic algorithm for the diagnosis of acute myocardial infarction in patients with left bundle branch block. So we're going to be talking about LBBB today, left bundle branch block. And so we can go through a little bit of history concerning left bundle branch block and how we tend to deal with it, certainly at least electrocardiographically. So way back in 1990, the American Heart Association essentially refers to left bundle branch block as more of a nuisance, really something in the way than anything else for the diagnosis of acute myocardial infarction, which is what we generally tend to really care about. Now, if we go a little bit forward, all the way till 2004, then we start treating a new or a presumed new left bundle branch block as essentially a STEMI equivalent. And so for these patients, they were really recommending that you take these guys to the cath lab and they're going to get PCI because you just assume, because we've already established that it's annoying, it's a nuisance, it's hard to read these ECGs for a STEMI. And so if they have it, just assume that it's because of an MI, even though there's a long list of things that could be causing or could have caused their left bundle branch block, and just take them for PCI. If we go a little bit farther into the future, a little bit more modern, then by 2013, we've actually abandoned that. So it's no longer considered a STEMI equivalent, and they've kind of retracted that. Now, interestingly, even in the European Society of Cardiology guidelines in 2017, they still recommend PCI for all patients with new or presumed new left bundle branch block, which is actually the basis which allowed these authors to do this study because of that little quirk, and it provided us with a lovely patient population. So what have we been doing in the meantime with a lot of these left bundle branch block patients? So there are a couple approaches to these patients, but I think one of the most common, or at least the most commonly talked about that I hear about, is the Scarbosa criteria. So in 1996, Scarbosa herself, I believe it's a she, made up the Scarbosa criteria. So we'll just go over them to make sure everybody's on the same page. So I called them A, B, and C just for convenience sake. They weren't originally named that. So Scarbosa A is going to be concordant ST elevation, concordant meaning that the QRS complex and the ST segment change go in the same direction. So concordant ST elevation more than 1 millimeter in any lead would be a sign of a STEMI. B is concordant ST depression, and leads V1, V2, and V3 would also be a sign. And then the last one is excessive ST elevation, excessive discordant ST elevation of more than 5 millimeters. Now, that was all the way in 1996. In 2012, Smith et al. Actually did a modification to these Scarbosa criteria, which really means that they upgraded these. And what they proposed was a change to Scarbosa C. So they proposed a proportionally, that they instead they have a proportionally excessive discordant ST elevation in at least one lead of more than 25% of the depth of the preceding S wave. So that means if you've got, so just like C was, instead of 5 millimeters, now it has to be 25% of however big the S wave was that preceded it. And this change actually offered a significant increase in sensitivity without harming the specificity. And we'll talk a little bit about those numbers soon. And then was also externally validated. And all of this, these Scarbosa criteria has also been externally validated for in use in pace rhythms, which is something that's relevant and interesting. So for all you visual learners out here, I just wanted to include this diagram just so that we're really all on the same page. I have Scarbosa A here, you see concordant ST elevation, Scarbosa B, concordant ST depression, and then Scarbosa C, you have the discordant ST elevation, either by the Scarbosa, which is labeled here as 5 millimeters, or by the modified Smith criteria, which are more than 25% of the preceding S wave. So what did our people really go out to do? So what they wanted to do was they want to improve the ECG diagnosis of acute myocardial infarction in these patients with left bundle branch block, because you still have a lot of patients that are being taken to the cath lab inappropriately. And so we want to reduce the number of times that we do that and improve our test characteristics so we can better treat these patients in the emergency department as well. So the modified Scarbosa criteria were quite specific, as were the original Scarbosa criteria, with most studies showing specificities of 90 to 100%. So they're doing quite a good job. If you see a STEMI by these criteria, then you can be pretty confident that indeed this person is probably going to need catheterization. But what they were really lacking is a lot of sensitivity. So the modified criteria were much better than the original Scarbosa criteria, but still the sensitivities were varying as low as 67%, but sometimes as high as 91%. The original criteria themselves were often in the 20s or 30% in terms of sensitivity. So what they're really proposing to do in order to better the characteristics of our Scarbosa criteria is to extend Scarbosa B, that is concordant ST depression, to instead of being in leads V1, V2, V3, to be in any lead. And what they also proposed was extending Scarbosa C to account for when you have a low voltage complex. Here I put low voltage in quotations because they actually derived what they considered to be low voltage based on their derivation cohort. So here, if you have a low voltage, which they ended up deciding was 6 millimeters or less to be considered low voltage, which we don't go too much into their data because I thought they did a fine job doing it, and it's not necessarily the most interesting part of the paper. And this only accounts for a very small, a number of people that would, it's a very specific numbers that you need in order to fall into this without falling into the other Scarbosa C criteria. Anyways, so if the low voltage less 6 millimeters or less, and they have 1 millimeter or more of discordant, actually they propose any deviation, discordant deviation, but not necessarily elevation, which is what was in the original criteria. So less than 6 millimeters is how big their preceding QRS is, and then discordant of 1 millimeter. So they wanted to test this, and they ended up naming this the Barcelona algorithm instead of the modified scarbosa, or the Barcelona modified scarbosa, or something cute. I don't know. I think I'll still keep calling it some form of scarbosa, because that's one of the coolest names for any of the tests we do, honestly. So let's look a little bit about the methods and get into that. So this was a retrospective observational cohort study, which was done in 4 hospitals in Barcelona. And what allowed us to have this really nice population do this study is that over there, like I mentioned earlier, their protocols are that a new or presumed new left bundle branch block in association with ischemic symptoms is still considered an indication for PCI. So this is a really lovely study population in order to test this kind of thing out, and you wouldn't be able to do this in North America. They included 163 patients from 2019 to 2014 as their derivation cohort. And then a couple of years after that, they had included 107 patients for a validation cohort. And then finally, they also recruited a number of controls, 214 total, which were patients who presented to the emergency department with left bundle branch block, but where there was no concern for acute coronary syndrome. Just to move on a little bit. So they had, oh, sorry, what is this? Oh, yes. So they had each of the ECGs were analyzed by 2 independent and blinded cardiologists, and the agreement was actually quite good between them. And then I mentioned this next point that I have in quotations here, which is that they say to mitigate the potential influence of unstable recording baseline, that they required that at least 50% of the complexes in any lead would need to be positive for that criteria for them to consider. I mention this just because it's not something that I think about when I'm reading an ECG. If I do see that it's positive, often all the QRSs are very similar in a given lead, unless there is some interference. But it's not something that I check for. So when I was reading it in the methods, I thought it was just an interesting point that I wanted to pull out as something to think about, because when they're validating this, then I'd like to analyze my ECGs as similar to their validation as possible, because that'll make my interpretation as accurate as possible.
We didn't have any good visuals for this, but I'm super visual, so I just wanted to put it there. I just put like a PVC in one lead, so we could say like we would never interpret the PVC as a regular QRS complex for this person because there's just one in that lead, so it's less than 50%. So in the same way, if they had ST elevation in just one of the QRS complexes or 2 of the QRS complexes here, they wouldn't interpret it.
Exactly. Thank you, Johan. And then they correlated this to whether or not there was findings of acute myocardial infarction on the PCI, or they also considered a STEMI equivalent group where they had acute coronary occlusion, or they had what they called significant biomarker elevation in the presence of no necessarily occluding lesion. So the next figure is just to sort of put it all together. Here's the actual little table that they had in the paper itself, which just shows us the actual criteria. So because everybody's a little bit visual and ECGs are very visual, I can quickly just show some examples that they included in the paper, which were some of their new categories. So here you have ST depression, because the majority of our QRS complex is going down here, and concordant ST. Sorry, you have a negative QRS complex and concordant ST depression of at least 1 millimeter, but this is in B5, which by the original criteria would not have met them. But here, this patient did indeed have an acute myocardial infarction, and despite this being in B5, and it's part of why they extended the criteria out. Now, in the next slide, you see here, we're talking about their modification to C, the Scarbosa C criteria. So here we have relatively small QRX complexes, 6 millimeters or less, but we have at least 1 millimeter of ST elevation, which is discordant. And they're an ABL. You see that it's a positive QRS in a ST depression. And this is still a patient that had a STEMI and otherwise would not have fit the criteria.
Hey guys, sorry, just a question from Dr. Floria, so what did they consider as significant biomarker elevation, like percent increase troponin or a threshold value?
I believe it was a percent increase off the top of my head. I don't recall what they did, but they actually, so they analyzed their data essentially twice, and they only talk about the significant biomarker increase. Like they buried it in their supplementals in the end, despite mentioning it originally, because, and the data was not different. It was not different between doing just a PCI and looking for actual signs of occlusion versus using the other definition of a STEMI equivalent. Maybe someone can find that exact number, how they for that.
Wait, is this it with a troponin rise and fall above the 99th percentile upper reference limit? Is that what they did?
Sounds right. I'll get back to you. So we have, here's just a few words on the study population. There was no real significant differences between the validation and the derivation cohort. The numbers look pretty good there. Here, I just highlighted a few things which are nice to see and kind of in keeping with a lot of data that we see previously, which are things that we know are kind of risk factors. So if you're male, you are more likely to have an MI. If you had a prior MI, you're more likely to have an MI. And then these people who did have MIs had lower ejection fractions, longer stays in hospital, and a more likely chance of mortality. All right. Now we talk just a little bit. So just to go over some of the numbers that we have here. So I originally had this as they would pop up one at a time, which was a little bit nicer, but that's okay. So here we have, you see on the left, we have the derivation cohort as comparing the Barcelona algorithm with either the original Scarbosa criteria or the modified Scarbosa criteria. And on the right, you have the same thing with the validation cohort. Why they decided to flip-flop between calling it modified Scarbosa versus the Smith criteria, I'm not exactly sure. And then here you see that they have 3, 4, and 5. And that's just because in the original Smith articles, they proposed slightly different algorithms, but mostly the same. And most people seem to treat the Scarbosa criteria as if you're positive for any of them, then you actually have a, yeah, thanks for going back. Then you're going to be positive for likely STEMI, which is why most people kind of use the Scarbosa score of 2 or more. So we see here that the Barcelona algorithm actually has a very good sensitivity at 93%, which is the main reason that we're upgrading these criteria, and that its specificity is nothing to cough at necessarily in the derivation cohort of 89%. And then the validation cohort, we see that it's very similar. Again, a good sensitivity, 93%, and the specificity of 94%. Now, when we compare that to the other algorithms, you see that it is significantly, a p-value of less than 0.1, better sensitivity than compared to all the other algorithms. And if we compare the specificity, then we haven't lost any specificity, except for here, there is a slight difference. There is a significant difference between that and the Scarbosa 3 criteria, with the Scarbosa criteria of 3 points or more, but having lost a little bit of specificity at the gain of 3 times as much sensitivity, I think would be worth it. And you don't actually see that change anymore in the validation cohort. So what they set out to do was increase the sensitivity and maintain the specificity at least, and they seem to have accomplished that.
Okay, so this is just to say, like very clearly, we talked about like Nick talked about sensitivity and specificity. As ER docs, obviously, what we really like to care about is, you know, the negative predictive value and the positive predictive value, because that's what changes our minds when we get that negative result for a specific patient. We want to know, like, what does that negative result mean? Is he truly negative or not? I mean, this is just to highlight the values to show that in the derivation cohort, we had a negative predictive value about 97%. And then with the validation cohort, we said they had a similar, so similar results at 96%. Sorry guys, we did our trial run with a not Zoom, and now all the controls are shifting. So the control population, they had results as well. And I just wanted to highlight this is that 21%, 21 of the 214 patients had a 10% positive Barcelona algorithm. So just to go kind of like back on our table here, you can see that now the spurs at the wrong area, but you can see that they lost maybe a little bit of specificity. And then 81% of these false positives were due to this new rule that they added, which was the one increase of 1 millimeter in the leads with a max voltage of 6 millimeters. So by adding that, they did lose just a little bit of specificity. So discussions and conclusions. So what's the importance of this study? So the Barcelona algorithm seems to be more sensitive with a greater non-negative predictive value than Scarbosa and its modifications. So they even, with their cohort, they analyzed, and in their cohort, they would have missed 67 patients with a Scarbosa score of more than 3, and 36 patients with a more than 3 with the modified Scarbosa rules. But by contrast, with Barcelona, they only missed like 6 patients. It reduces the amount of PCI for no reason, so obviously reducing costs to our social healthcare here in Canada, and it would reduce invasive procedures and exposure to contrast for patients. You know, we know that exposure to contrast can sometimes cause anaphylaxis, and like if you believe in it, contrast induced nephropathy. So limitations of the study. So the ones that were listed by the authors, firstly, it's observational. So the observational nature of the study made some things impossible to truly evaluate, and they did not evaluate the time course of EKG changes after revascularization. So we're not really sure of like if any of these criteria kind of go back to normal afterwards, and any of the other EKG changes. Limitations of the study that we considered. So it was evaluated by using like 2 independent blinded cardiologists, not necessarily ER doctors. So is this usable for ER doctors? However, the 2 cardiologists that evaluated had a very low kappa, even lower than Scarbosa. So we can probably extrapolate from this data that it's quite easy to use and will have better, more agreement between the reviewers. Low voltage has a criteria. So this is like a soft limitation because we don't all agree on this. But low voltage of a criteria can maybe complicate interpretation in the ER, where sometimes our EKGs might be of lesser quality, or we don't really have the time to really look at the EKG. And mostly the point that I'm getting to about that is that there's no ability, like this study didn't evaluate morbidity and mortality using this score. Mostly like the main goal was to reduce the amount of PCI. So is that really what's better for the patient in all? Just to give you an example, like low voltage EKGs, when we get something like this is just a bad quality EKG. Will we consider it? Will we start being more confident saying that this low voltage doesn't have anything to do, like is negative, so we're fine? Or will we want to redo the EKG and we might not? That was just a soft conclusion that maybe this should be evaluated in ER use in the ER context. And it's very specifically for between 4 and 6 millimeters, which is what Nick was trying to say earlier. It's very, very specific because under 4 millimeters, technically having 1 millimeter is 25%. So it answers the previous Scarbosa rules. But when you're between 4 and 6, that's when 1 millimeter isn't 25% anymore. And then over 6 is not included in this rule. So it's really, really specific patient population. So not that much in the end. The strength of this study is that it's the largest left bundle branch study. It's only an N of 484, but we haven't really found anything much bigger than that. And it was compared to the gold standard diagnosis. So they did use the troponins, as we said earlier, but like all these patients, they did PCIs, and then they could compare 2 PCIs to see if there was exclusion or not. And there wasn't any exclusion criteria. So the conclusions of the author, word for word, is that Barcelona significantly improved the diagnosis of acute myocardial infarction as compared with previous EKG rules. Our conclusion is that it may improve management and resource allocation in the futures. Of course, more studies have to replicate these findings, and that's a little hint to Antoine's part. It's to be evaluated if appropriate to ER use, and if significant reduction of morbidity and mortality. It is promising compared to the modified Scarbosa criteria for left bundle branch block. We can, I think we all consider that 484 might be a little bit low for a population. We'd like to see, obviously bigger numbers than that. And Scarbosa has been studied many times in pace rhythms, and this one was really only in left bundle branch block. So to see if this could be validated for pace rhythms would definitely be an ask.
Just to jump in and properly answer the question in terms of the STEMI equivalent thresholds. So that what they were using was a ratio of the troponin or the biomarker elevation divided by the upper limit of normal, and so a ratio of greater than 10. So when your biomarker elevation is 10-fold the upper limit of normal, that would be considered a STEMI equivalent. Yeah.
You're muted, Antoine.
All right, so as this is a 40-minute presentation on some very specific topic, just gonna ask everybody, especially those with their cameras, just to get up and just do a quick turn around your chair, just look a bit in distance. So at least we're able to reground ourselves and be able to refocus a bit. Thank you, guys. All right, so just to be reactivated in this presentation, so at least we're back in the game. Okay, so let's jump into it. So my topic goes a bit with what this study was. So replication or validation studies. Basically, we're going to talk mostly about the replication crisis. All right. So the replication crisis is not a sequel of the Star Wars, Clone Wars. Indeed, it is actually a real crisis that affects most fields in the scientific world. So let's start with the definition. So reproducibility is, according to the NSF, the ability for a researcher to duplicate results of a prior study using the same material and procedures. So basically, it's either you can use the same data with a different team, or you can use the same methods and protocol and use your own data with that to validate into a different population. Then, if you use the same data with the same team, it's simply repeatability instead of reproducibility. All right. So why would anybody do something that has been already done by a different team? It's not really glamorous, just it almost looked like piggybacking on something somebody else did. But it's actually how good science is made. There are some studies out there, and they're more into really statistical and epidemiology based, but they actually prove that a lot of studies out there are, there's a high rate of false positive. So basically we're basing what we're doing on something that looks positive, but is actually false. And with those validation studies, we can prove either that the previous study was wrong or that indeed they were right. Just in the previous one. So they actually did a study using a very simple set of data and 29 different teams. And only by changing, and basically the 29 teams, they were told that this is your data set and use whatever method, whatever statistical analysis you want to do on those numbers. And just with that change, actually 20 groups had a statistical significance, while 9 of them had a non-statistical significance. So that also goes to say that you can change your data with fairly easy methods. So why is it very important? Let's say we all learned with this big new study that came out that carrots are good for vision. So you go to the grocery, you buy a hulk of them, and you just munch on them all the weekend. For actually having a second study that says that maybe it wasn't the case. So I'm just humoring here, but it's just to show that sometimes, and especially in the medical field, a lot of studies are contradicting each other. And in this case, maybe you just got fed up with carrots or spent a few bucks on carrots. So the effects aren't that bad. But if we go to the next slide, here, actually, with the case of TPA, there are 13 major randomized trials out there, 2 which support the use of TPA and 11 that don't, even 3 of which had to be stopped prematurely as they were causing too much harm. So we're far from the carrot here. Like, you're talking about human lives and about quality of life. And therefore, it is even more important to have good validation studies in those specific cases. But the case also comes that more often than not, the first case, the first study that was out there is the one with the biggest impact, even though you might have a second one that contradicts the first, if, let's say, the second one is even more thorough or well built. So next slide. So the crisis itself comes from 2 main facts. Basically, the first one is it's not done enough. We don't do enough validation studies. There are some few out there, as we did with the Scarbosa criteria and the Barcelona, or let's say the Ottawa rules. But still, there's not many studies out there. And one of the big reasons why is that people just don't give the ingredients. So according to Johnson et al., a study out there in 2020, basically in emergency medicine specifically, we lack the components needed to reproducibility. So we just don't share that data out there. And the numbers are pretty they talk big. So factors that can be contributing into this crisis. So we really have this publish or perish mentality, and that makes the will to really publish bigger, and therefore we need to have big case, big headlines, and it's probably not good, especially for the reproducibility crisis. So if we remember our finer criteria, when you look up to what should I do for my research project, the N in finer is for novelty. And that kind of goes against the validation study, doing something somebody else did before you. I've also checked, and there is no mention of validation study in the guideline, in the guidebook for the research from the CanMed. Also, funding for sensational research. There's no incentive for negative data because of the publication bias. No publishing of negative data because of financial or controversial issues. So big pharma don't want to publish something that says that indeed it goes against their pill. That's one. And then promotion or status associated with big studies. So we all know those big names out there, they were made big because they published big studies in big journals with big impacts. That's what made them famous. Most of them actually are super great and really thorough researchers, but they're not necessarily mis de l'avant because of that thoroughness, more because of those big publications, and that has to change. All right. So also for the trainees and researchers, there is a poor awareness about that specific issue right now. So as I said, in the Royal College Research Guide, there's no mention of the crisis or of validation studies. Then, as I mentioned earlier, there's this lack of sharing, as if you would have a secret recipe from your protocol. And in the study of Johnson et al. From 2020, they say that only 25% of researchers in emergency medicine actually do share a protocol. So the other thing is intentional p-hacking. So as we said, there is some ways to just change the way you analyze your numbers and gain statistical significance versus non-statistical significance. So if you, not necessarily with playing with the numbers, but playing with the way you analyze the numbers, you can make or not make your study say something different. And then there's also the spinning the results of the abstract, which spin is basically misleading interpretation or even extrapolation of results. And this is seen even more in RCTs done by pharmaceutical companies, but at large in emergency medicine RCTs, you have spinning in 44.5% of those studies, which is big. And then, of course, any underpowered study is a poor study. And that kind of contributes to this crisis of creating more false positives. So this was very pessimistic to pointing out everything that was bad. But what can we do actually as a residency program, but also as researchers? So first, in the journals field, they have to encourage research mostly based on the exemplary methods more than for the big headlines. That has definitely to change. They can even do a section reserved for validation study in every journal they publish. Then encourage researchers to give access to their data. And one specific way to do that would be to force them to put a data availability statement. And that has been proven to be effective. Then to remove or at least raise the word limits for the method section. But there's also ways to put a link in your method section for which you can have either an annex or a free access kind of a Dropbox or server in which you can drop it. And then the other thing is for journals, they have to ask more studies to actually pre-register. So that makes more of them follow their protocol. Then from the community, we also need to change our mentality and our mindset. We need to base promotion or big status, as I said earlier, on quality more than those big headlines. And then there must be some sort of incentive to do more validation studies. Then another component that was raised in some articles that I read is the accessibility. They say that if we remove accessibility restriction, it would make more place for more validation studies. Basically, in this presentation, I've put the link for the open access button, which is basically a site, or you can even upgrade it as an extension to your Google Chrome. But once you get on that page that says that you can't really access that study because you need to pay whatever, either McGill gives you the access, or if you click on that button, it can give you access to it, but it doesn't have it from some free and legal way. It goes through the internet and trying to find a page that publish it without any access. So that kind of extends your access to most of them. And if it's unable to, it will ask your email, so they would put you into connection with the writers. And there you can ask, like, yes, I need this article because I'm doing a validation study or blah, blah, blah. So that's some sort. And another thing is maybe there are some debates out there that we should move the significant p-value from 0.05 to 0.005 to actually have less false positive. And even though we might have less positive results, at least we'll know that the ones we have are true positives. So just a quick reminder for pre-registration in RCTs. So when you pre-registrate, you're held accountable to your original protocol, so you can't really move from there. And the FDA in 2000 actually made that mandatory for RCTs. And here you can see that with this forest plot, most of the studies before were actually staying out of this line of no change. But now we're more, since then, we're more like either saying that, no, the previous study, we're saying the same thing. We're basically, it makes it more reliable. All right, and finally, for the researchers, basically we have to share this mentality. We can also use standardized framework. So the repeat framework is an example. It's a checklist of 119 components that makes your study more transparent and more, let's say, pro-validation study for somebody else to after that use your study. And then we have to be more specific and more detailed about our methods. And as I mentioned before, there are those external public access data banks that are out there where you could drop your protocol or methods and even your raw data. But the raw data is a topic of itself. Some people are for it to be shared with everybody, and some say that it will create its own bag of problems. And then we have to educate. So this is kind of one of the things to talk about it. But the NIH in the United States has done training modules on reproducibility, which are I think 4 or 5 neat small videos that explains it in a better topic. All right, that's it.
Great, a good 1, 2, 3 punch of talks there. So, comment from the crowd. Dr. Floria also added that there's a link to an article that describes a good template that should help improve replicability for observational data. So that link is in the chat right there. So, all right, guys, awesome work. Yeah, great review. Thank you so much. So we will move on to scooter injuries with Holly, and very excited to see what you have to tell us about that.
All right, I'll just share my screen. Everyone can see?
Yes, can see your screen right now. It's in the presenter mode.
Good, I'm going to just put it to the screen.
Perfect.
Hi, my name's Holly. I'm one of the R3s in the CCFP EM program. And today I'm presenting on e-scooters and trauma. What is the pattern? I have no conflicts of interest. I'm not a major shareholder in any of these companies. So I chose to present on this topic because in mid-2020, I found myself in Calgary, and I noticed that they had these rentable e-scooters in Calgary. And it's very convenient. You scan a barcode on a scooter with an app, you pay per the minute that you're using the scooter, and you can go several blocks at a time, you can go farther. And while I was on this scooter going 20, 25 kilometers per hour with no helmet, I thought to myself, could this really be safe? Am I about to seriously injure myself and end up in a Calgary emergency department? And luckily, this article was published in May 2021 in the EMJ. We'll get further into it a little bit later on, but it talks about risk factors and the injury patterns that you see in people using e-scooters. It's also an important topic, and people are talking about it from a public health perspective as well. But rideshare modes of transportations are becoming very popular, and I'm pretty sure they're here to stay. There's a multitude of reasons why they're so popular. One, we're always looking for greener transportation, less greenhouse gas effect. There's also a rising cost of gas associated with using traditional modes of transportation like cars. And in tourist cities, especially densely packed cities where you're just going a couple blocks at a time, it's very convenient just to hop on and off of this rideshare transportation that you can rent just for a single use. And tourists might not have access to monthly passes for metros or buses or anything like that. And that could be part of the reason that they are so popular in European and American cities, not so much in Canadian ones as of right now, but we are seeing a rise. There's also very few laws regulating these types of micro-mobility devices, so things that are used to only go a few or a short distance at a time, which are very frequently electric modes of transportation. In Montreal, we don't really see them. They were actually banned in 2020 after a trial period. So maybe if you practice in Montreal, you won't be seeing so many of these injuries. Obviously, you can still use them as a private citizen, but there is no rentable scooters in Montreal. But I did want to include some information from Bixi Bikes that I'm sure everyone is aware of, that Bixi Bikes in Montreal being the rideshare bikes that we can rent either as a monthly user or as a single use. And in their most busy months in August and September of 2021, they boasted upwards of 200,000 users. You can see in the orange that their monthly users typically stay the same through each month, so about 14,000 users. But the large base of their consumer base is single use or single use rents of their bikes. So you can maybe think that people are using them as a single use. Maybe they're not coming prepared to use them either. Maybe it's a convenient spur of the moment decision and they're not wearing helmets. For those of you that don't know what an e-scooter is, it's just this electric scooter that with the handlebars you brake and accelerate. The max speed limit is 15 miles per hour, 25 kilometers per hour approximately, which is not insignificant. It's pretty fast when you're standing on just a scooter. Something I did want to point out as well about e-scooters compared to bikes is that bikes have a very large front wheel, or well, both wheels. And looking at a scooter, you can imagine that in a large city with uneven pavement or potholes or even tram railways that can happen in the middle of certain the streets in certain cities, they can actually get stuck. The wheel is a lot smaller in diameter and in thickness. And if you fall or hit a pothole rather, you can imagine that that small wheel that doesn't have a lot of shock absorption to begin with can act as a fulcrum, get stuck and project the rider. And most of the time people using these probably aren't wearing helmets, as this guy in the picture is demonstrating for us. So just before getting into the article that I'm presenting for you guys, there's an increasing number of articles that are talking about these accidents and just micromobility accidents in general. Most of them are retrospective studies, and a lot of them were from Europe. And I'm not going to be talking about these articles, but a lot of maxillofacial surgery, orthopedic articles as well, because that's the bulk of the injuries that we see. In September of 2021, the US Consumer Product Safety Commission did publish a statement about micromobility and e-scooters usages, because they did notice that since 2017, when these products and these rentable e-scooters were introduced in many United States cities, they noticed a sharp increase in the amount of injuries that they were seeing in emergency departments. So in 2017, they only saw 7,700 visits for e-scooters. And then in 2020, 2019, you see this amount tripled to 25,000. They attribute most emergency department visits for micromobility injuries to e-scooters as well. So back to the article that I wanted to talk about. It was a prospective observational study in Berlin, in the city center of Berlin. They examined people presenting to 4 major emergency departments in the city center between June 2019 and December 2019. And they included 248 people in this study, essentially all people that presented with e-scooter related trauma. In 2 of the centers, they only looked at clinical data, the pattern of injuries essentially. And in 2 of the centers, so about 120 people, they implemented a questionnaire that the patients filled out before being seen. And the goal of this was to gather some other information, some details about the users themselves, to find out if there was any specific risk factors that would make it more likely for people to get injured on e-scooters. And this included whether they had a driver's license, whether there had been alcohol use associated with their injury, if there was previous experience with scooters and e-scooters, and what the cause of the incident was. In people that responded yes to alcohol use, they actually gave them a breathalyzer test to find out what the alcohol content or their blood alcohol content was. This is also assuming that people presented immediately after their accident, didn't account for people that were presenting a few days later after their accident and were no longer intoxicated. I just wanted to show you guys where in Berlin these centers are. They're very close together. Just to give you an idea, between CCV and CCK on this map, there's about 5 kilometers. So it's a very tight region in Berlin, and it doesn't really account for other areas of the city. Okay, so just to talk a little bit about some results, you can see that among the 248 patients, male and female distribution was pretty even. The age was a very large range, between 5 and 81 years of age, but the majority of patients that were presenting with injuries were between 18 and 40, so a pretty young demographic. 58% of people presenting to the ER with injuries were from Berlin themselves. They lived in Berlin, and 41% were tourists. So it's a pretty big population of tourists that presented with injuries. This graph shows the distribution in time of when these injuries occurred. So kind of similar to Bixie bikes, we see that August and September appears to be the busiest months, or at least the months with the most injuries. And most of the injuries happened between noon and midnight. And going back to the previous slide, a significant amount of people said that they were using the incident occurred on the way to work, so about 8%. Most of them did occur on the weekend as well, most injuries. So this is some information that they gathered from the questionnaire. Most of the injuries were due to loss of control or balance. So they said that this was more user related and lack of external forces causing this accident, and more because either they were not concentrated or they had one hand only on the handlebars. Some more information, just to let you guys know, 20% of the people that presented with injuries claimed to have some alcohol use associated, and the vast majority of the people presenting with injuries had a driver's license as well, so about 68%. Talking about the pattern of injuries, which was really the goal of this study. It wasn't to talk about the incidence of injuries, it was more to describe what type of injuries people were coming with. So these categories are not mutually exclusive. So one person could present with multiple injuries in different parts of their body. So they saw that limb injuries represented 72% of all injuries, so the vast majority. And they found that the lower limbs as compared to the upper limbs were more frequently injured, but this number was not statistically significant. The p-value was not significant. And in all categories, upper limb, lower limb, head, and torso, soft tissue injuries represented the vast majority of injuries that they saw. Talking about fractures, despite the fact that the lower extremity was injured more, they found that there were more fractures in the upper extremity as compared to the lower extremity. So going back to the previous slide, 17% of the injuries to the lower limb, 7% of injuries to the lower limb were fractures, as compared to the upper limb, it was 17%. They also found, and they pointed out in their article, that there was often an injury of the medial malleolus, whether that be soft tissue or otherwise. And they hypothesized that this was related to the fact that the rear wheel of the scooter itself was quite bulky, and there was a screw that kind of jutted out from the scooter. And when you're about to injure yourself or get into an accident, you tend to drop your feet from the scooter. And the common joke being that scooters like break your ankles when they swing out. So it was hitting the medial malleolus of people's ankles, which could be significant considering that medial malleolus injuries typically tend to be more surgical. Drawing your attention to my bright red box, you see head injuries, which is really what I was concerned about. Obviously, soft tissue injuries being the most frequent injury, but there were quite a few fractures. Most of the fractures were maxillofacial, mandibular fractures, really of the face, but they did report one basal skull fracture, and there was one intracranial hemorrhage. Of note that they remarked that a positive alcohol test or positive alcohol breath test was associated with a 5-time increase in the odds of having a traumatic brain injury, and they were more likely, twice as frequently or more likely to be admitted to the hospital if they had an alcohol test that was positive. Talking about hospitalization, the number that they provided in the article was that 49% of individuals presenting with injuries required a surgical intervention. And they go on to describe that ambulatory surgical intervention includes suturing and casts. And then 25% of people presenting were admitted to the hospital, and 23% underwent surgery while being admitted to the hospital. So discussion, I think some positive points about this article is that it was multi-center in a large city. Most of the studies up until this point, including one study done in Vienna looking at similar pattern of injuries, were retrospective and relied heavily on accuracy of charting and the doctors charting exactly how people got injured. And this one was probably one of the first prospective studies, or the only one that I came across. They did report a higher incidence of lower extremity injuries as compared to upper extremity injuries, when previous articles had it the other way around. They saw more frequently upper extremity injuries. And this study had a higher hospitalization rate compared to other studies. So they reported a 25% hospitalization rate in this study, when compared to, for example, that Vienna study I was talking about, there was only a 15% hospitalization rate. I think an important difference to make between bikes and e-scooters as well, because there is an argument for rentable bikes. Are they really that safe? But in bikes, the most common cause of accident or injury was collision with other vehicles. And in e-scooters, the most common cause of injury was user error or inattention. It was basically without an external force, people were getting injured. And this could be related as well to more poor maintenance of the devices themselves. So there is a definitive increase in the number of e-scooter related injuries. I think that's pretty undeniable. Ever since they've been introduced in 2017, everywhere they've basically noticed this trend. But it's difficult to know whether these people would have been injured regardless. So for example, if you say 20% of the people presenting with injuries were intoxicated or had alcohol use on board, could we really say that these people would not have gotten behind the wheel of a car and injured others or injured themselves at the same time? So is this a risk reduction element of, driving while intoxicated? It's hard to say. And with all these alternative methods of transportation becoming more popular, are we seeing a decrease in the number of injuries in cars, for example? I didn't look into it, but that could be an interesting place to take this. With alternative transportation, are we seeing less car or vehicular transportation? Again, the different mechanism of injury with bikes is an important factor to take into account. And I think what's very interesting about e-scooters is that because they're so new, there's very few laws, and certain states in the United States, for example, California, are coming up with laws and stricter regulations about what should be done to prevent injuries. And in this article, they actually suggested either creating a minimum age requirement to be able to use e-scooters, such as 18 years of age, and mandatory helmets. They did remark that the majority of maxillofacial or facial fractures that the people presented with in this study were unlikely to be prevented by the standard bike helmet because they were very much of the face, but who knows? There were clearly some limitations of this study. Number one, likely because a large consumer base are tourists, it's possible that people with minor injuries or tourists with injuries didn't present to the emergency department for medical attention. Maybe they didn't have health insurance, or again, minor injuries, they were probably treated by more primary care. They also only provided the questionnaire of the risk factors to 2 of the 4 hospitals, and it was a lower sample size, most likely just because there weren't that many injuries as compared to the population. They also only studied the city center, which I think is important. All the hospitals were within a very tight radius. I'm sure that if they expanded it to more hospitals within the city or the outer boroughs of Berlin, because Berlin is a huge city, they might have found either a different pattern of injury with different pavements or different roads, or even a different incidence of injury. Their definition of hospitalization also wasn't very clear in the article. So they talk about being admitted to the ED for 6 hours of observation, specifically with TBIs. And I wasn't sure if that was included in their rate of hospitalization or not. And then they talk about 49% of participants requiring surgical intervention and go on to discuss that that included sutures and wound care. So I wasn't quite clear on whether what this number 100% represented, but we do have the 23% number of people requiring surgeries as an inpatient. And that kind of leads into one of my future points, is that they didn't follow patients long-term. So it's possible that people with soft tissue injuries or meniscal injuries would require a surgery in the future, but because they only had a 6-month observation period, we don't have that data. So going forward, these rideshare options are here to stay. Bixi bikes are very popular in Montreal, and it's possible that we have more methods of transportation going forward, but we need more regulations and we need more standardized regulations. For example, in Calgary, you're only allowed to use them on the sidewalks, which could be quite dangerous for pedestrians. But in Montreal, I believe they didn't want us to use them on the sidewalks. It was only on the road. So it's very dependent city to city, and it's hard to keep up with the rules when you travel. Should helmets be mandatory? I think probably yes, but the majority of people using these are using them for one use at a time. And are they going to be carrying around a helmet with them at all times? Hard to say. Another interesting thing about these rideshare options, specifically for the scooters, because Bixi bikes and other similar bikes, they have a docking station where everyone needs to bring their bike back. They can't just leave their bike in the middle of the road. But for the scooters, what's convenient and also unfortunately annoying about them is that you can leave them anywhere. You can leave them in the middle of the street, in the middle of the sidewalk. And it impacts the aesthetics of the city as well and can get in the way of other people trying to share the space. Another interesting point that could be brought is that should there be a minimum age or a requirement to have a driver's license in order to use one of these scooters, which would probably decrease the amount of people that would use them, but would help with safety. The way they charge for these scooters as well is a bit counterintuitive to safety, and it encourages more risky behavior such as tandem riding, because you're charged a base price just to rent the scooter, and then per minute the majority of people are charging that way, and that encourages increased speeds to get from point A to point B, because you don't want to be charged as much. So that's my presentation. It was a bit short, but hopefully it helps us get back on track. And I was wondering if anybody had any questions.
I guess I don't see many scooters around in the wintertime. Like, do they take them away like in the winter?
They
Okay.
do, just like with the Bixi bikes, they kind of like go around and collect them all and bring them back to their base. Yeah. Otherwise, that would be quite dangerous, I believe.
No, I'm okay with them removing those during the winter. Yeah.
Yeah.
Probably wouldn't be that great on a hill anyway.
No.
But yeah. Okay, awesome. No, it was great. Thank you so much for that review. Great, thanks. Okay, so we are moving on to the final presentation of the morning. Agmin is going to be giving a presentation on dermatologic considerations, cues, and pearls for patients with dark skin in the emergency department. So go ahead, Agmin.
All right, let me just set everything up and let me know if you're able to see. How is that?
Yeah, looks good.
Perfect. Okay, amazing. Okay, so hi everybody. My name is Ahmin. I am a PGY2 in the FRCP program. So today I am not going to repeat the title because Jake did a fantastic job and it is long enough as it is. First disclaimer, the available literature on the subject is very, very scarce and the resources are limited. And so I'm gonna try my best to present what I know and hopefully we're all gonna learn something today. I do not own the rights to the pictures that I've used in the presentations, but the citations and the links are all available if you need. And it's only an overview. So the subject is extremely broad. I'm hoping that you're gonna stay curious and that you're gonna try and get more information after this presentation. Very brief summary. So the rationale behind the presentation, we're going to discuss a little bit of the literature as well, physiological concepts. I'm going to present a little bit of basic ED presentations related to that. We're going to do a few practice cases, talking about some resources, and then the take-home messages essentially. And then hopefully lunchtime, because I think we're all very, very hungry. So we're going to try to do this quickly. Why are we talking about this? And then before we talk about the why, let's talk about the what. So the Fitzpatrick scale is a scale that is used widely in dermatology to determine what is the characteristic of the skin type depending on the tone. And they use that to kind of based essentially on how the skin reacts to UV rays. When I talk about dark skin today, I'm going to be referring to type 5 and type 6 on the Fitzpatrick scale. Now, what is dark skin? Essentially, it is melanin. That's what we know. And where is it produced? Well, when you look at this, the cut of the skin, you look at the dermis, you have the epidermis. At the basal layer of your epidermis, you have melanocytes that are dendritic cells that produce melanosomes. And those melanosomes contain the pigments, contain the melanin, and that is going to travel through the dendrites all the way up to the keratinocytes. And those keratinocytes will store the melanin and release it as they need to the superficial layers of the skin, essentially. Now, there are two types of melanin. I learned this, I didn't know. Pheomelanin and eumelanin. Eumelanin is the brown pigment, and pheomelanin is more of a reddish pigment. The reddish pigment, so the pheomelanin, when it is exposed to UV rays, has a tendency to produce a little bit more free radicals, which means that a fair skin that is usually more, that contains usually more pheomelanin is more at risk of developing skin disorders, like, for example, skin cancer or sunburns, as simple as that, when exposed to UV rays, because the pheomelanin, when exposed to that ray, is going to react and produce free radicals, whereas eumelanin is a little bit more protective. And that's why people that are more exposed to UV rays, so people that live in regions of the world that have more sun, will have more eumelanin because it is a protective factor. So now that we spoke about the what, let's talk a little bit about the why. In Canada, we have 1 in 5 Canadians that are people of color. And the images that are provided to us in the medical curriculum and at large do not fully depict who we have as a population, and that's especially true in Montreal, for example. And we're going to discuss a little bit more about that, but late and misdiagnoses can be associated with an increased mortality or morbidity, and that is something that we want to avoid, especially when we are in emergency medicine. I don't know if you guys know about this young gentleman. Maybe some of you do, maybe some of you don't, but I'll present him very briefly. He's Chidibere Ibe. He's a first-year medical student in Nigeria that became extremely popular in December 2021 because of this image. Simple image, simple illustration that he made himself that represents the sagittal cut of a pregnant woman, as we've seen 1,000 times. But the difference in this case is that the woman and the baby are of dark skin. Why people took this image and kind of shared it over and over on social media, on Twitter, and he was even broadcasted on CNN, was because this image is kind of one of the first representations of the kind. And when you used to do a Google search for anatomical representation, pregnant woman, you did not necessarily find people with dark skin in those illustrations that were made. Now that he posted this, there are a lot more that are coming up, and his goal is eventually to increase the representation of dark skin in medical textbooks, in resources, for regular condition, for anatomy, and as well as for specific conditions that are medical in nature. So he's making a lot of those illustrations, and he's hoping to become a neurosurgeon, which is quite interesting. And so I thought that was very interesting, and that would be worth talking about. And Chidibere Ibe is actually not the only one. When you think of this, as a medical student, as a resident, we realize that we don't have a lot of exposure to dermatologic conditions at large. Like, we don't have a lot of exposure to dermatology throughout med school, throughout a residency, and even less so when you think of the fact that most of those representations that we get are on fair skin. And so if we're not taught how to recognize those same conditions on various skin types, then it can be a lot harder for us when we get to work and we're trying to recognize those conditions on different skin types. So why am I talking about this a little bit more today is because simply when the skin color is underrepresented in textbooks, it also has an incidence on how we integrate that knowledge in our brains, essentially. And one of the studies that came out in 2020 shared the lack of representation of those images in dermatology textbooks. So what they did is they looked at 6 very well-known dermatology textbooks and 2 online basis resources. And they looked at a total of about 15,000 images. And through these images, they looked at 65 specific cutaneous conditions. And they searched for representations of Fitzpatrick 5 or 6 on the scale that we talked about earlier. And they noticed that only 19.5% of the images were images that were presented on darkest skin. Now we can wonder, oh, well, is it because simply those conditions don't happen very often in people with darkest skin? But what they did is they looked at those conditions that actually had a higher prevalence or incidence in people with darkest skin. And they looked at the number of images they were able to find, and they realized that even for those, there was a lack of representation. So you take lupus, for example, which is the little blue box there, where you have an incidence that's about 30 times higher in the African-American population compared to the general population, yet there's only 1 image out of 4 that was presented on dark skin. Another great example of this is during the COVID-19 pandemic. So another study that came out in a research letter, to be more precise, that came out in 2020, looked at all of the images that were associated with the articles published to present the cutaneous manifestations of COVID-19. A lot of articles came out during the pandemic to try to find ways to recognize the disease. And some of these articles were very specific to cutaneous manifestations of the disease. And they looked at a total, if I'm not mistaken, of 36 articles. And of those 36 articles, 130 images were found to kind of present what it could look like when you have COVID on your skin, essentially. And no images were of Fitzpatrick 5 or Fitzpatrick 6. So 0 images out of 130 that were presented on darker skin. So then you can wonder how, as a physician, when you're looking at those articles, how are you supposed to interpret this and use it on your patients that have darker skin to be able to recognize the pattern of manifestation of the disease? Another thing that was figured out during the COVID-19 pandemic was related to the pulse oximetry. And so an article looked at the pulse oximetry and realized that more often than not, actually 3 times more often than not, the pulse oximetry failed at recognizing occult hypoxemia in the Black patients. And what do they mean by occult hypoxemia? What they did is they looked at about 50,000, so 50,000 measurements of SpO2 and arterial oxygen. So they looked at 10,000 patients total, approximately, all of whom had a SpO2 between 92% and 96%. And they looked for those patients, when they looked in the arterial blood gas, what was the actual oxygen for those patients when it was taken at the same time. And they realized that 3 times as often for the Black population compared to the white population, when the SpO2 said 92 to 96%, the arterial blood gas was actually revealing an hypoxemia that had not been picked up by the pulse oximetry. And so the hypoxemia was 88% or lower on the arterial blood gas. And so much so that the FDA actually put out a statement recommending their physicians to be careful and mindful of the pulse oximetry when using it to interpret the oxygenation in the population with darkest skin, because sometimes it cannot be as accurate as you would like it to. Another study in 2021 actually repeated the results and also paired them with morbidity and in-hospital mortality, and realized that that was also associated. And it is extremely important when we think of how much we've used during the pandemic the pulse oximetry to help us, guide us into how we manage the patients that come through our ED. So who gets oxygen, who doesn't, and who needs admission and who doesn't, because For 2 patients that present with a shortness of breath complaint and a COVID positive test, we need to be able to allocate the resources properly, and we need to be able to make sure that we don't hospitalize unnecessarily, but we also need to make sure that we recognize those that do need hospitalization. And we did use a lot pulse oximetry to help us through that. Another example, again, and again, we cannot directly necessarily relate the representation of dark skin in the literature to patient outcome, but we do have a responsibility to wonder if it is one of the factors that's contributing to it. And when you look at skin cancer, for example, it's another thing that you can, on which you can question yourself. When you look at melanoma or non-melanoma type of skin cancers, the population with darker skin has a much lower incidence because of what we discussed earlier, the eumelanin being a protective factor. Despite having a lower incidence, they have a mortality that is way higher. And because the mortality is way higher, then we have to wonder, is it also partially because it is recognized later? And now it might be because the patient consults a little bit later, but it also might be, we could question ourselves as to, is it possible that physicians don't recognize those diseases in those populations early enough? And so when they present and it is actually recognized, they're already more advanced, they're already at a later stage, and the disease is already more aggressive, and so the mortality increases. And for us in the emergency department, it is important as well because our goal is often to be able to recognize quickly, efficiently, and accurately who needs referral, prompt referral, who can be discharged safely home. So the data that I show you so far is kind of at large. It's more dermatology related. But what I found interesting is that another study came out and evaluated this specifically in emergency medicine journals. And they looked at a total of the 6 most influential emergency medicine journals, essentially, and they looked at 314 images of cutaneous presentations that we recognize in the emergency department as being emergent cutaneous disorders, non-emergent, and then simply not classified. And when they looked at those images, they realized between 2015 and 2020, 300 images, they realized only 15% of the emergent cutaneous disorders, so those that we should be able to recognize quickly and to act on promptly, were represented on Fitzpatrick 5 or Fitzpatrick 6, so on darker skin. And so again, for us in emergency medicine, the images that we have access to help us and guide us into treating our patients are unfortunately not diverse enough to help us. So a few questions that I was kind of wondering as I was thinking about this and thinking about this question at large is, well, how often is rash the presenting complaint for us in the emergency department? How often is the continuous appearance, how often does that serve us for us as a hint onto what's happening to our patients, how much we use that to think of what's going on, and how often are we the safety net for those populations that have difficult access to a primary care physician when they do have those questions about their skin, for example. And lastly, how important it is for us in the emergency department to be able to distinguish between what is benign and what is a serious issue that we need to assess very, very quickly. And for us, the general appearance is very important in our gestalt, right? We see a patient and we comment pretty quickly on, well, he looks okay, he looks bad, he looks sick. There's this weird rash going on. We're not too sure what's going on. And I don't know if you're like me, if you've heard this before, if you've ever said this yourself as well, is sometimes I have heard while being in the emergency department, well, I was not able to assess the redness of the patient because the patient has dark skin. And that happens because it is not something that we see often. So if we don't know how to recognize it, well, we can't really comment on it as well when we see the patients. Moving on to this gentleman. So some of you might recognize him. Let me just make sure I get everything. Okay, perfect. So Some of you might recognize him. If you don't, it's fine. I'm not gonna fault you for it. Michael Jordan, great basketball player. I'm not biased at all. Essentially had an interview that came out about 2-3 years ago, I think. And in the interview, people commented right away on the color of his eyes. People were very focused on that. And it was a question whether or not he has cirrhosis, et cetera, et cetera. Now, I have no idea what the medical record of this gentleman is. I do not know if he has cirrhosis, but what he may have, though, is racial melanosis of the conjunctiva. And that is a thing. So you'll see that people with dark skin, as they get older, they have pigmentation of the conjunctiva that makes it that it looks a little bit more yellow, a little bit more brown. And that can be confused with a sign of cirrhosis. Now, let's not ignore those patients that may have cirrhosis, and let's investigate them well, but also it is worth it to keep it in mind that melanin can be deposited pretty much anywhere in your body. Another example here is simply this. So in the gums as well, you can have deposits in the nail beds as well. It is normal. It's called longitudinal melanonychia, essentially. And so that's something that's interesting to know. Of note, there's a type of melanoma you can see on the nail that looks very similar to this, but the way to distinguish whether it's physiological or more cancerous looking is whether the coloration extends all the way to the inguinal nail fold. So if it goes all the way up and it touches the regular skin on top, then you might want to question yourself a little bit more. And Michael Jordan is not the only one that had kind of the situation where people were wondering if he had cirrhosis when he may not. Like just last week, I had a patient that was signed over to me, and in the notes, in the OASIS notes that were made for him, there was a question mark about 64-year-old, abdominal pain, diarrhea for 3 weeks, et cetera, no signs of jaundice, but dark sclera, query cirrhosis. So interesting to kind of keep in mind. Another example that I'm presenting here is a case of a woman that was published in 2016, a case report. And this woman, unfortunately for her, had 7-year history of going back and forth to the doctors, complaining about paresthesia in her upper extremities. Upper extremities, lower extremities, mostly the fingers and the toes. And so she was never fully investigated. Nothing was really found for her. And eventually she presented herself to the emergency department with a 3-day history now of worsening symptoms and changes in the color of her skin that became dark. And she was essentially found to have gangrene, as you can see on the pictures there. After further investigations, it was found that she had a connective tissue disorder that was associated with a secondary Raynaud phenomenon that had been unrecognized for so many years, simply because the hallmark for Raynaud is oftentimes the biphasic change of color associated with the paresthesia, associated with the cold induced, and she only had the cold inducing of her paresthesia without the biphasic change of color, so it was not recognized. And unfortunately for her, the treatment for gangrene is amputation. So she did sustain morbidity consequences for her diagnoses that went not recognized. And so a few things, yes, we could be wrong when we recognize physiological manifestations of certain things in some patients when they actually have a disease, or we could think they have a disease and then it was actually physiological. So it's important for us to kind of question ourselves into that. So that was my introduction. I try to make it as short as possible, and now we're going to start working on it a little bit more. So I'm going to need your participation, please. That would be much appreciated. I'm going to try to see if I can open the chat as I'm presenting this to you so I can see your answers as we're going. Perfect. Okay, so basic presentation. Feel free to comment, put whatever you think, don't hesitate. I'll be looking at it and nobody is here to judge you. We're all learning here. So what do you see in that image? I'm gonna wait for a few responses before we move on. Look at it closely. What do you notice when you look at it? And then we can see what we think it is.
Malarash.
Interesting. Okay. So we're going right away with the diagnoses. I'm fine with that as well.
So instead of being more red, is more purple.
Yeah, yeah, absolutely, absolutely. And then I see another answer that says left-sided erythema, lupus. Very interesting. Okay, so if I show you this, and now I move on and show you the comparison right there. So we see there are similarities in those two images, right? It's just we have to take a second to stop and stare and look. On the left side, you do have the redness that's very obvious. The malpresentation, as you said, yes, absolutely. I agree with you, Humaid, and I agree with you with the chiefs. The redness, the way it is localized, absolutely. And when you look at the patient with darker skin, you can see that there's a difference between the skin around their eyes, on the bridge of their nose, and what they have just over their mouth or what they have over their eyelids. So as Antoine said, it doesn't look as red, but it definitely looks different, and it definitely looks a little bit more purple. There's a glow that's a little bit different. You can see that it looks a little bit puffy there. And the best recommendation that I can give you today is to stop, stare, and ask the patient. That is something that I'm going to say repeatedly. I think it's the best thing that you can ever do. If you're not sure, ask the patients. The patients are the best people to tell you what is wrong with them. And when they look at themselves in the mirror, they will be able to tell you, yes, I noticed that this is a little bit more red compared to my usual. This is a little bit more purple. The tone of my skin is different compared to my usual. Okay, so it is worth it to stop, stare, and ask. Other one. What do you guys think?
Redness of the skin, like cellulitis.
Yeah, absolutely. I agree. So cellulitis. And so there is a little bit of pencil marking that is also kind of giving you a hint as to what's going on. And I agree with you, definitely cellulitis. So when you look at it here, you can see the difference right away. Absolutely. So you see the redness on the left side, but on the right side, you do see redness as well. It's just, it is a little bit more subtle. You see versus, cellulitis versus erythema, I agree. And you see that there is a little bit of swelling as well. And then if you ask the patient, they will be in pain. If you touch, it's going to be tender, et cetera, et cetera. So you have more ways to recognize that as well. Next one.
Psoriasis?
All right, interesting. So I have psoriasis that has been proposed. I have urticaria for sure. And then trying to take a second before going right away into the diagnosis, I'd like you guys also to try and describe what you see. Because when you have to describe that to somebody else, you want to be, for them to be able to visualize it in their mind. So what do you see?
There is like redness also.
Sorry, I had two people at the same time.
Go ahead, you made.
Thank you, Antoine. Like there is some kind of redness also.
Yeah, definitely. Antoine, you were going to say something as well?
I was about to say it's more like some plaques that are a bit more pale with a few satellite lesions around it.
Yeah, absolutely. And then I have also papular rash. Yeah, definitely. So you have the swelling, right? You have a change in the thickness of the skin, depending on where you're looking at on the patient. And you do have a little bit of redness, as you said, definitely. So the color is not the same. There's a difference in color for sure. When you look at this and you compare it with that, you could see that on the patient with the lighter skin tone, you could notice the redness, whereas on the right side, you can't really see the redness. I would have to agree with you. Depending on the lighting, you might see it a little bit more purple, but you wouldn't see the redness as well. But one thing that you can notice, though, is definitely the swelling. You can notice the follicular spacing as well. And that can help you kind of recognize. And it's geographical in terms of positioning. So I would have to agree with you guys, urticaria for this one. Okay. Moving on to the next. What do you notice on this one?
There is definitely change of the like lower lips color comparing to the upper one. I would say because of the swelling, we see more the mucosal surface. Could be a little bit reddish.
Yes, absolutely. Absolutely. So definitely agree with you, Humaid, on that one. And so I compare it with this picture. It's not the same. Definitely, you could see that on the right side, you have also puffiness in terms of the edema around the eyes. But it's interesting for the lips as well. As Humaid said, there's a difference in color. Now, it is very possible for a patient with darker skin to have a very dark upper lip and pinker lower lip, and vice versa. But what you have to notice, as Humid said, is that the edema around the lower lip seems to be more pronounced, and you can see the early aspect of the mucosa there. And the patient will tell you, my lips are swollen. Very, very simple. So early angioedema, definitely agree, in the answers in the chat. Yes, yes, definitely. Okay. Now, pallor and cyanosis. I wanted to just quickly touch base on that one. I do think it is interesting. So on darker skin, you might not notice pallor and cyanosis the same way, but there are ways to work around that. So you can look at the nail beds, you can look at the mouth, the mucosa, you can look at the palpebral conjunctiva, you can look at the palmar creases. So you look inside and you're gonna see that the pallor of the lines is different. The patient is also gonna tell you. That's why I always say ask. And so you're looking at the mucosa a little bit more, right? So you're gonna look at the lips, you're gonna look at the tongue, and you're gonna notice these differences. What do you see on this one?
It's more of an hyperpigmentation.
Yeah, more of a hyperpigmentation. Definitely agree. Yeah.
Is that like the reverse psoriasis? Or impetigo, actually? It's just a weird localization for it.
Tinea. That could be tinea.
Interesting. Yeah, definitely. So yes, so you do know this, that there's hyperpigmentation around the breast, so in the inferior border of the breast compared to the rest of the stomach. Now, that pigmentation seems similar to what she has on her hands, right? But she would probably tell you that normally at baseline, her abdomen is the same color, and then the rest of her skin is a little bit different. But that is definitely odd for her. Irregular shaping as well of that hyperpigmentation there. You can see that it's a little bit moist, it's a little bit shiny, right? So all of these things tell you tinea. Yeah, that tells you fungal infection essentially, okay? Whereas the fungal infection, when you were gonna see it on whiter skin, you're gonna see it with the redness associated. Whereas on the darker skin can be more correlated to hyperpigmentation rather, okay? What do you see here?
Diffuse edema of the hand with maybe some reticulation in the skin.
Yeah.
Almost a marbré.
Yeah, absolutely, absolutely. And then the swollen digits, as I see in the chat as well. So yes, so definitely swelling. Very, very obvious swelling. So much so that the skin is tense. So much so that if you look at the B image, if you look at the thinner eminence, you can see that it looks a little bit brownish inside. But then when you look a little bit further, just close to the crease, there's a change in color, right? So it looks very pale in the middle and then a little bit more dark here. And you can wonder if that's because the swelling is so prominent that the tensing of the skin makes it that you have paler in this side. And it is very painful. Yes, definitely. Very, very, very painful. And if I compare it to that, then what diagnoses come to mind for you?
Cellulitis or tenosynovitis.
Is it like burns?
It could be burns, yeah, because you see the bully. Anything else that would be even more concerning for us in the emergency department?
Compartment?
The patient is at risk for compartment syndrome.
Compartment syndrome is definitely a risk, yeah. And
neck fash.
Neck fash. I heard it. Yes, thank you very much. So I heard it, neck fash, absolutely, okay? So that is one of the things that you definitely have to keep in mind, right? And so again, on the darker looking skin, the redness is not gonna be as obvious, so you have to use different hints. And the patient is probably gonna tell you that his skin is not looking as usual, and there is probably gonna be a difference between that hand and the other, so you could compare that way, okay? A quick touching base on the laceration and sutures in the patients with darker skin that are prone to keloids and hypertrophic scars. I'm just giving you this very, very quickly. It is a risk. It happens more often in patients with darker skin. It is worth for you to ask the question, when you're about to do a suture? Are you prone to keloids? The answer is very often, they will very often know the answer. And if the answer is no, and the 25-year-old, is usually because it's never happened to them. And so you can just discuss that with them. The only reason why I'm telling you this is because it doesn't change much in the way that you're going to manage the patient, but it changes the way you're going to communicate with them, and it's going to manage their expectations as well. The same way we tell them when we do the sutures that it's not going to be perfect, but we're going to do our best to approximate the wound, and it is going to leave a scar and this and that. We also have to manage the expectations for our patients with darker skin that are prone to keloids and prone to hypertrophic scars, if it's the case for them, because they need to know that it is a risk. And so how do we avoid increasing the likelihood of that happening for them? Well, we do prompt closure like we do with everybody else. We avoid excessive tension on their sutures like we do with everybody else. We try to be very precise in the aversion of the skin. And we try to avoid dead spaces even more so, because dead spaces are spaces where the scar can become hypertrophic. It leaves space for the scar to become hypertrophic and to develop keloids. And we're going to try to avoid that. If you can do subcutaneous sutures, go ahead and try it out. That apparently could help. And the last thing is, do not try to excise this yourself. Don't try to remove it. Even if the patient asks you, do not try to remove it, because if you remove it and you don't have an adjuvant treatment on top of that, so for example, intralesional steroids or cryotherapy that is done by dermatology, if you don't do that, then the risk is that the keloid is going to come back and come back even bigger. And so the patient is going to be very disappointed, and you're likely not going to know because you have done it in the ED, and they're not going to be able to find you to tell you that it grew back even bigger a few months later. Okay. Practice cases, and then we're going to try to do this very quickly, but have fun still while we're doing it. So I show you a picture, I show you a case, you tell me what you think in terms of diagnoses, we talk about it very quickly, I say a few words about treatment management, and then we move on to the next one. We have 5 to go. Okay. What do you see?
Is it an herpetic lesions?
Aha, who made right away with the win. Herpetic lesion. So we have a gentleman that is 55-year-old, stressed lately, pain in the area, otherwise in good health. That is making you think of?
Zona, zoster.
Zoster, herpes zoster, yes, absolutely. Shingles, definitely, okay? So that's not the same gentleman, normally only one dermatome, right? But I just wanted to show you different images so that you could see it and recognize it, okay? So very quickly for the treatment management, if you have a Hutchinson sign, you have a lesion on the nose, think ophtho, think IV antivirals. If the lesions have been there for less than 72 hours and they continue to appear, think antivirals. If they have a lot of pain, you can think adjuvant therapy, but that would be more for complicated cases. And then if they still have lesions going on, definitely tell them to avoid being in contact with people that never had varicella, just because we want to avoid sharing that little thing. Next one.
We just see the picture in the corner.
Yes, that's the point.
If it's tender, I would ask if it's maybe more bruise, or maybe after that I would, if it's non-tender, I would go more towards something fungal.
Okay, what about this one maybe? It's all the same diagnoses, by the way. It's just different images on different patients.
That looks almost more like an abscess with some cellulitis on the shoulder, but it's hard to
Yeah,
see.
cellulitis too.
Yeah, it looks a little bit more reddish. You do notice the redness there. You notice the area that's a little bit different. What about that then?
It's really circular.
Mm-hmm.
Erythema migrans.
Okay, very interesting. Is that? I heard a question.
I'm blanching the tick disease.
Lyme disease.
Lyme disease, definitely. So he did go on a hike with his
Lyme, thank you.
Definitely, Lyme disease, okay? So the target lesion, erythema migrans. Yes, you notice on all of those lesions how it looks a little bit circular. You have the difference between the outer layers and the inner layers, right, of the rash. And so when you look at it a little bit more closely, you question them a little bit more vividly, then you get Lyme disease. And then you can see the comparison between the two. How do we treat it? Doxycycline PO, essentially. We do have to question them about neurological, cardiac, or articular manifestation, and that is also going to contribute to our treatment. If it's isolated, usually the course of antibiotic is for 10 days. If it is more disseminated, they have more than one lesion, or they have systemic symptoms associated, 14 days of therapy, that is more recommended. Okay, moving on. We're going fast. It's going well. What do you see here?
Macular papular rash.
Maculopapular rash. Yeah, yeah.
Almost like sandpaper.
Almost like sandpaper. I like that. Yes, definitely. So you have like the how do you say that? Not surface, but I understand what you mean. The texture. Yeah, that's what I wanted to say. The texture. You can notice the texture that's a little bit different. Contact dermatitis is a question. Interesting.
Is it only on the back?
No, it is not only on the back, but it's mostly
Psoriasis rosacea.
Interesting.
Rosea? Not rosea.
No, if it's diffuse, I would go more like you made. I think I saw in the chat, it popped up. I go with scarlet fever.
Scarlet fever, interesting. So mostly on the torso for this young gentleman. 7-year-old, 7-day history of fever, bilateral conjunctivitis, cracked lips, perianal inflammation. What's coming to mind now?
Kawasaki.
Kawasaki.
I heard it. Yes, absolutely. Kawasaki disease. Okay. So very important. Then again, it is a condition that is important to know, especially in the peds population. So as soon as this fever has lasted more than 5 days, you want to keep that in the back of your mind. And then the rash that comes with Kawasaki is kind of very obvious. Looks exactly like that on the right side, but you have to be able to recognize it as well on the back of skin. So the difference there, the redness is going to be a little bit more subtle, but you'll definitely have the sandpaper feel that Antoine described, right? The texture difference. And then you question a little bit further and you're able to find more information. So how do you diagnose that? That's the 5 days, more than 5 days of fever, and then 4 out of 5 of those following symptoms. So the conjunctivitis, the mucus changes in the mouth, et cetera, and then whether they have partial or full cartia for Kawasaki disease, you definitely have to treat. You determine first the risk for IVIG resistance. So for the Japanese patients, there is the Kobayashi score that you can use. And then for the other population, there are different scores. I'm not going to go into details of that because that would be way too long for today, but you can find that information up to date if you're interested. And then the treatment essentially is IVIG, aspirin, and then if they are at high risk, then you want to consider prednisone on top of everything else. What about that?
Like it's scabies.
Yeah, right away. Boom. So 10-year-old young girl, she went to a friend's house to play and is super pruritic and she has lesions in other places of her body, and the little sister started to scratch as well. So yes, definitely, you guys got it. Scabies. Yeah. Okay. So the treatment for this, topical permethrin, very often, that's what we do. The other option is oral ivermectin, but you can't do that with everybody. We avoid it in children that are too young and in pregnant ladies. So oftentimes the topical is going to do the trick. You have to make sure that you treat everybody in the family, and you have to make sure that you tell them to put their clothing out to dry, hot cycle clothing and linens in the house, and or put them in a sealed bag for 72 hours. If it's very, very pruritic, you can give them antihistamines on top of it to help, or topical corticosteroids sometimes just to help with the scratchy feeling. What do you notice there? And this is our last case for today.
There's definitely like redness with the urticaria.
Mm-hmm.
Coalescing plaques.
Yeah. Yeah, definitely. So you have the plaques, right? I'm going to show you another image that is a little bit worse than this one. It is all in the same family of disorders. That's what we're going to talk about. What do you see?
Isn't there a form of, no, there's a mucal. I was about to say, I think there's a form of psoriasis that can do something like that, but not with the mucal application.
Stephen Jones?
All right, Hamid. So definitely. So 22-year-old female, recurrent UTIs, was put on Septra for the first time in her life, essentially, after an antibiogram that revealed that the bug was essentially sensitive to Septra. She was put on it, and then for the last 3 days, she hasn't been feeling too good. Chills, fever, flu-like symptoms. She has pain associated with that new rash that she has all over the body. And then the mucosa is involved, as Antoine said, so you could see the lips that are also involved in the rash. When you look and you see the images, yes, so we're talking about DRESS, Steven Johnson, 10. These are the type of diagnoses that derm is going to take you seriously if you do call them. They're not very worried about anything, but that they are going to be worried about because it is more of a dangerous presentation. So yes, drug induced, definitely. DRESS versus Steven Johnson's versus 10, a little bit different, but quite similar in the sense that they're oftentimes drug induced. There are specific triggers that are quite known. So allopurinol, lamotrigine, and other anticonvulsant sulfas. In children, for Steven Johnson specifically, Mycoplasma pneumoniae is also a bug that can be associated with it, so to just keep in the back of the mind. Now, the difference between DRESS and like Steven Johnson and 10 that are on their own continuum, DRESS is a little bit more associated with like liver involvement. They have hematological anomalies, so eosinophilia, atypical lymphocytes. It is oftentimes pruritic, and it's quote unquote less bad. Steven Johnson and 10 are on a continuum, Steven Johnson being the milder version and 10 being the toxic epidermolysis necrotic, so being a little bit further down that same continuum. And the continuum is based on the amount of involvement of the total body area, essentially. So less than 10% is Steven Johnson's, more than 30% is 10, and then everything in between is kind of like a mixed presentation. How do you treat that, manage that? You identify it and stop the offending agent. You consult derm or plastics or ophthalmology if you have ocular involvement if necessary. For DRESS, you can consider topical corticosteroids for symptomatic management if the disease is quite mild. You could go systemic if it's a little bit more severe, if you have lung or kidney involvement, for example, and cyclosporin may provide added benefits, apparently. Steven Johnson and 10, you might want to consider, you will have to consider, admitting them or transferring them to a burn center or a unit if it is a large area of their body that is involved, because it is dangerous. It puts them at risk for secondary infection. It puts them at risk for death, as simple as that. You have to replete the volumes. You treat them like a burn, essentially, a severe burn. So you replace their volume, replace their electrolytes, you put burn type of dressings on top of it. You manage the pain plus. And then the question of systemic corticosteroids, IVIG and cyclosporin, is a little bit controversial and there's scarce data, but it is worth a try. No need for prophylactic antibiotics, but you do need to be very, very careful to see if they have secondary infection, because if they do, they will need proper management for that. Almost done with the presentation. Useful resources that are interesting for you guys to know. Skin of Scholars Society, it is one of the resources that I'm referring to that is interesting. They're essentially an organism or they're a company essentially that provides these information about the manifestations of different diseases on skin of color, and that's kind of their goal, is to just make sure that the representation is out there and available. And so for COVID, they did publish this when they realized that there was an issue with the representation of COVID manifestations on darker skin. They presented what it could look like so that people had it readily available at the top of their fingers. And then you could see here the COVID toes to kind of look at the difference. I don't know if you guys can see my my pointer, but you could see that around the toes, on the darker skin, you have a little bit of the redness, right? The difference between the tip of the toe and the more proximal area is definitely different. And you compare that to the other side, and you can kind of see there. Books that are interesting: Mind the Gap. Mind the Gap, that came out in 2020, is a very tiny book. It is a PDF. It is available online. It is, the quality of the pictures are not quite there yet. Again, it is a little booklet handbook that was made by a medical student in the UK, if I'm not mistaken, that is also kind of addressing those same issues and presenting some of the very common diseases on the skin, on darker skin. Ethnic dermatology is another one that's kind of interesting. On social media, if you're interested, Brown Skin Matters are worth a follow. They present a bunch of diagnoses on darker skin, and present the difference sometimes with paler looking skin. So it's interesting to just have them on your social media, because you can just consult those pictures whenever you'd like. And they are also all on Twitter. Skin of Color Society also is another one. So if you want to follow, give them a follow. That's interesting, because you get exposed to those without having to look for them. So that's interesting, personally, I find. Visual DX is a very, very, very interesting platform. They have essentially the widest online base, the widest online based stuff, let's say, for images associated with derm conditions and any other condition, really. It's not only just derm. And they present it on all types of skin, and they oftentimes have a very, very wide representation of different types of skin. And they also have this very cool engine that's coming up as well, that's called Derm Expert, where you can just take a picture of a lesion and they will be able to identify it and tell you what it is and give you indications as to how to manage it and stuff. So that's super interesting. You technically have to pay for it if you're a resident or if you're a student, but I know they are interested in communicating with programs. So I think University of Montreal, University of Sherbrooke is trying to like get involved with them. I don't know about McGill yet, but I think it might be a thing. So that could be interesting to kind of have in the back pocket for the program, to have access to this database. Take home messages, and then we're done, guys. Thank you so much for listening. So the very, very first thing, as I said, I was going to be annoying with this, but that's my main message. If there's one thing that you're going to remember from what I said today, stop, stare, and ask. That's it. Take a second, stop, look at it, trying to wrap your head around it, and then ask your patient, what do you notice there? Is that your usual tone? Is that the usual color? Is it the usual texture? And then they're going to be able to tell you, because they are the main expert of their own experience. Don't assume that it's normal or abnormal. Correlate it with the story, with the physical exam, with what the patient is telling you. When you can't look at the skin, look at the mucous membranes to try to get some more information. And take the time to comment on what you observe and your knowledge, so that we can avoid saying things like, I don't know because the patient has darker skin. You do know, take a second to look at it, and then it's gonna be great for everybody. Keep getting informed, find the resources, use them, and then pay it forward. Whatever you learned today, teach these principles to your learners, teach it to your seniors as well, because we can teach something to everybody. And that is it for me today. Thank you so much for listening.
Fabulous. That was super good. Questions?
I would just echo the fabulous. Different topic, very well brought. Good job.
Thank you so much.
Excellent. Yeah, thank you so much. All right. If no questions, we apologize that we kind of went over like long today, but I think every presentation was great. So this was a lot of fun for us. So thank you to all the presenters, and have a great afternoon. Oh yeah, so they're 1:30 recess hour. Yeah, and hopefully we'll see you all there. Okay, thanks everybody.
Have a good week. JK, you want to stay on?